Shebula, which is part of the, being a tannin-containing drug, is known for its wound healing activity. And besides this, it's a wonderful hepatoprotective activity being used in the various liver disorders. And apart from it has been used in the diabetes condition also. Next, please. This slide you can hold for a while. So you can see that from the antioxidant to anti-inflammatory wound healing. So drug has a tremendous potential being used as a traditional medicine across the world. Next, please. And the muletti or the glycyrrhiza glabra. Recently, one research paper has signifies its role in the treatment of the peptic ulcer. And since the drug is well known as an expectorant and being used in the various uh, Khasi Sharbat and all the cough remedies. Beside this, the drug has a very, tremendous potential being to treat the glycyrrhizinic acid, which is the active phytoconstituent being used as a, in the treatment of the peptic ulcer. Next, please. This is the summarization of the various activity being reported in the drug. Next, please. Then piper longum, which contains the piperine, and piperine, as August House is being aware that in the pharmaceutical sector, it has been used to, enhance the bioavailability of the certain drug which are, poorly bioavailable and required to be enhanced the bioavailability so that the overall drug being, shows the better efficacy. And beside this, the drug, has been used in the as an antioxidant, effect, yeah, as an antioxidant in some of the disease conditions. Next, please. So this is the summarization of the various activities. Next, please. The other drug, the next drug is the mostly safed or the chlorophytum. Next slide, please. So the drug is also a well-known aphrodisiac drug being used, as a aphrodisiac in the many Unani formulation also. And beside this, the drug has a tremendous potential being as the, you know, to enhance the overall immune system. And these days, a lot of cornflakes and so many other preparation, a very ready-made preparation available in the market which contains the safed mostly. Next slide, please. So that I have already discussed. So next slide, please. And amla is one of the most widely used drug across the world, and because of the very high content of the vitamin C in the drug, so automatically it's a wonderful antioxidant drug being used as a hair vitalizer across the lot of shampoos and hair care products are available which having. But besides this, the drug, you can see the next slide, please. So this is just the summarization that how the drug has a multifaceted pharmacological effect, being the considered as the inhibition of the free radical formation and being the antioxidant. And in a lot of Chawanprash you find the amla as a chief ingredient, and because of that the memory enhancing property, anti-cancer activity has been reported, anti-diabetic activity has been reported, anti-ulcer, immunomodulatory, neuroprotective, antimicrobial, anti-inflammatory, and hepatoprotective. So drug overall one of the best drug, and the best thing is that the drug is very easily available. ये कोई बहुत महंगी ड्रग नहीं है, ये एक एज ए ड्रग आप इसको आजकल तो कैंडीज भी आ रही हैं मार्केट में जो सिंपल आप उनको चीव कर सकते हैं कभी भी. नेक्स्ट स्लाइड प्लीज. The adrak or ginger is also a very well-known carminative drug. अदरक पाचा की इस तरह के जो फॉर्मुलेशन है मार्केट में बहुत अवेलेबल हैं. So being excellent carminative, the drug is being used in the various stomach related problems. And since some of the drug diseases being originate from the stomach only, so for that purpose this drug are for the regular use of for the better working of the stomach. So lot many other activities also being reported. Next slide, please. One antidiarrheal activity also being reported with the ginger. Next, please. katha or the acacia catechu. So it also has a very good wound healing properties, and since the drug has a very high content of tannin in this, so the bark and the katha, apart from the the commercial use in pan masala sort of industry, but overall as a medicinal plant, it has a wonderful immunomodulatory as well as the anti-inflammatory activity. Next slide, please. So you can see the overall the medicinal importance of this drug. Next, please. The next drug is the cinnamon xylenicum or the darchini. Next slide, please. So drug also has a very, very apart from being a flavoring agent, since the drug is very easily available and it has a good taste also. So even the tea of various type of, cinnamon has been used across the world. But the drug has a very good potential being a antifungal or the antibacterial effect apart from the astringent effect or the wound healing effects. Next, please. Balela or Terminalia bellerica also. Next slide, please. So you can see that clockwise, it has also have a very, proven pharmacological effect, including the antioxidant effect, hepatoprotective, neuroprotective, cardioprotective effect, and also in the treatment of various inflammation. Next, please. Aloe vera, we all are aware that it has a tremendous potential. The drug being used as purgative also, the aloe vera gel. And as far as the skin problem, the cosmetics is concerned, we all know that the drug is a drug actually of choice for all the herbal cosmetics. Next, please. Next, please. Fova or the Rubia cordifolia also has a tremendous potential as a Unani drug. Next slide, please. You can see the summarization of the some of the prominent pharmacological activity being reported in the drug, which include the wound healing properties, being also has a very proven role in the treatment of the gallbladder problem, which is a common problem, the stone in the gallbladder. Next, please. The gudal or the hibiscus, although the plant has a very ornamental value and also being used in the various herbal cosmetic preparation. But apart from this, next slide, please. You can see again the it has been used to as a anti hyperlipidemic drug to decrease the LDL level in the body, and the lot many cardiovascular diseases being otherwise causing the problem due to the high triglyceride and the high LDL levels. So for the treatment of such condition like atherosclerosis, the drug and the main constituent of the drug being used. Next, please. The burgas, which is a well-known, plant. So next slide, please. So again, you can see that the drug has a tremendous potential as a being the immunomodulatory drug and has a very versatile effect, being the hepatoprotective to wound healing to anti-diabetic drug. And for this reason, many of the formulations I have seen that which contains this particular drug in the Unani formulation also. Next, please. The Nilophor or the lotus tree also has a very tremendous potential as being the antioxidant drug, and apart from it has a proven role as an anti-obesity agent. Next slide, please. So you can see the some of the potential of the drug being mentioned in the slide, being the anti-obesity and also an anti-diabetic agent. Next, please.
Lots of time.
Sir, only 2 minutes. I'll take 1 minute. So next is the well-known the Karika papaya, and as sir has just mentioned, that there is only 1 or 2 minutes left. Like the condition, like in dengue, the pattiyan of papita tree has been being used to increase the platelet count. So this is one of the major activity being reported. Next slide, please. Next. Was one. Next, please. So next drug is Giloy. Next, please. Was now mentioned, member. Next, please. I think audience can just see the next, Delhi se chali. Next, 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 please. Thank you very much, and I hope I adhered the timeline. So, thank you very much for.
It's not a very good thing to curtail a wonderful talk, but then we have time restrictions and other things to follow. With this, I call on our next speaker, Professor Suhail Parvez, Head Department of Toxicology, School of Chemicals and Life Science, Jamia Hamdard, New Delhi. He will be speaking on role of Unani medicine in targeting Alzheimer's disease. Before that, I request the chairperson, Dr. Mushtaq Ahmed, and Dr. Muhammad Zaid Ashraf Saab to please felicitate our earlier speaker, Dr. Tanveer Navid, with a memento and a flower. Dr. Suhail Parvez, please.
So thank you for the introduction for Professor Suhail Parvez. I just want to quickly add on two lines. You know that his CV doesn't reflect what actually he is. He has been one of the most proactive neuroscientists in the country, and again at various forums I said that if Unani has to excel, they have to engage the dedicated or the committed scientists who are there in the modern sciences. So he has done excellent work in neurosciences. He has various models. I don't know what he will show today, but if any of you want to do some good study on depression, on the neurodegenerative disorder, Alzheimer's, Parkinson's, any of them, I think in the interest of time, I'll not drag further, and I'll request him at least to share his, contact so that all of you could be benefited. Over to you, Doctor.
Yeah. Uh, Assalamu alaikum and good afternoon, respected dignitaries on the dais and after dais, and all here today. Due to shortage of time, I will just quickly go through. Thanks a lot, Dr. Zahid, for your kind words. Currently, the trends that we are seeing is all dependent on the funding we have. We have many fields, but as of today, cancer and neuroscience remarkably are adding to the applications as well as the funding, as well as the core areas of the funding agencies. And I would like to highlight when we talk about neuroscience, then we have many diseases, and among them, because of the epidemiology and the numbers, AD and PD, they mark quite significantly. If you look at the global body burden, uh, it is that the increase in the next 15 years would be more than 68%. And as of today, uh, anybody who is above 60 is definitely at a risk. And if you look at these numbers, 2 out of 3 who are having dementia, or every 3 seconds, you will have a dementia patient. And technically, when we talk about AD, it actually falls under the entire umbrella of dementia, which marks more than 50% of the cases. And as of today, uh, when we look at the I'll just skip this part. When we look at the market, most of the drugs that are there, they're only focusing on two things. First, being the acetylcholine esterase inhibitors or the NMDA agonist. So these are the two things. And when you look at the drugs that are available in the market, donepezil, donepezil, gentamicin, all of them are actually focusing on being the ACHE inhibitors. And if you look at the economy, if you look at the numbers, we technically don't have any good medication that is really taking care of this. So when you look at the pathways, everybody is targeting either the amyloidogenic or the non-amyloidogenic. That means you have the beta amyloid or the neurofibrillary tangles or the tau. So what happened was, based on this, a new drug came into market, and this is Aduhelm. And the best thing, what I could see from the literature, is that when you type in PubMed, Unani and India, you get only 9 hits. And out of those 9, there is no paper that is telling you about a formulation of Unani and Alzheimer's. But the best paper from that lot is from CCRM. It's a recent update where they have very nicely summarized what exactly this new drug is doing, what exactly the aducanumab is doing. And that is really amazing. So that means the funding agencies have realized that everybody would like to work on AD and PD. Now is my insight that what is important, that okay, we have these fibrils and we have so many other medications, but the problem is we are only working on active principles, we are only working on the active constituents, we are not taking the entire Unani formulation as a whole. And then it comes to my next point is, we have this traditional drug discovery, we have a new term which is known as drug repurposing. And this drug repurposing is a short window, not taking the whole thing. But the problem is, drug repurposing is only limited to the modern medicine. We have not tried the traditional medicine, either Unani or Ayurveda, and take it to the level of repurposing. Now, what we showed in a recent review was that there are certain pathways and certain hits that need to be targeted. We showed that there is an amyloid beta hypothesis through the APP. We tried to explain how fibrils and oligomers, these are different things. The fibrils actually form the senile plaques, but the oligomers, they only produce neurotoxicity. So if you have a rat model, a preclinical model, you need to induce the AD not with streptozotocin. You need to induce the AD by injecting them with the A beta fibrils that will develop the senile plaques. Then only you can target the rats. So we also had the cholinergic hypothesis, why we are acting on the ACHE, why ACHE is important in Alzheimer's. Then the tau hypothesis of Alzheimer's, why we have the normal tau protein functioning. Tau is not a villain. Tau is within us for a reason. When this normal tau functioning changes into tau protein aggregation, that's the problem. That's where the whole problem lies. And then we have the neuroinflammation hypothesis and the whole calcium hypothesis, where you need to target the mitochondria. So this formed the basis of the study for us. Now, alternate models, as Professor Shizai had pointed out, we have the Drosophila and the C. elegans. It's virtually impossible to test 10 or 15 Unani formulations in animals. It will take 3 to 4 years and it will take more than 2,000, 3,000 animals. But what we can do is, we can have transgenic Drosophila, transgenic C. elegans, and make a short-term basis study where you shortlist them, where do you preliminary studies, and out of 10 or 15 potent, you take one or two. And then you take it further to the preclinical rat model. So there are people who are working on C. elegans. I have, like, for example, a C. elegans transgenic facility as well as a Drosophila one. And I am the newest or the beginner into Unani medicine. Very recently, CCRM was kind enough to give me a project, and now I'm working on developing these things in terms of Unani medicine, and I'm looking forward to it, because sky is the limit. When you talk about Alzheimer's, I'm again a novice in this field. You actually take Alzheimer's to the concept of Nisyan, and you have the three: the Zikr, the Fikr, and the Takhul. So these three things actually form the basis of Alzheimer's in terms of Unani medicine. And we have so many things that are going on. We have, for example, let's skip this part. The traditional medicine, you can see you have so many things, but they are all focusing on many other things, but not Alzheimer's. So, what we would like to do is, we would like to take Midhania Sominafir, which we call as Ashwagandha. But in Unani, it's Habbe Asgam. So you need to really take the whole formulation as it is and then try it first in a Drosophila model or a zebrafish model or a C. elegans model, and then show that why, as a transgenic, if it is doing something, that is your clear evidence. You will get even animals from animal ethics if you go show them the convincing results from your transgenic experiments. So ashwagandha is a very potent one. People are doing it, but we have to take it to the whole formulation level. At the same time, uh, this particular report, this is Vijay Lakshmi Ravindranath, published in Journal of Neuroscience. She is the ex-director of NVRC, now in the Neuroscience Institute of IISc. Groups like that, they are working on within the Suminifera. So just imagine how much potential we have in Unani medication, which is completely unexplored. So sky is the limit for Unani medicine. And again, my good friend Dr. Tanveer was talking about Emblica officinalis, which we again know it as uh, the medication where we say Jawarisha. We also had one of our researchers, Professor Raisuddin. He actually showed it that how it can be used in cyclophosphamide induced toxicity, anti-cancer induced toxicity remediation. So if you take this, put it into the concept of Alzheimer's, then that is the drug repurposing of Unani medication. So there are people working in Middle East, for example, Egyptian traditional herbal medicines. They are using drugs like this and using it in Alzheimer's disease. So I would request all of you that we should not only focus on drug repurposing with the modern medicine system. We should always use the other systems that are involved. We can even try doing some of them that we have done. It's very preliminary because we just got the project last month. So Majune Brahmi. And what we did some talking experiments with the constituents of Majune Brahmi and the experiments with Drosophila. I don't have the final data now, are very promising, where you cross the Alzheimer flies so that you get a transgenic one and you can test them. So So I would just like to finish here because of the paucity of time that real models are those that reflect. If you take a rat model and if you induce any agent with it, it will be mimicking only the toxicity symptoms of that. It will be beta amyloid induced neurotoxicity in a rat. But if you have a transgenic fly or a transgenic C. elegans system, then that would really reflect. So together with a transgenic system, if you can prove something even in a rat model, that would go a long distance in proving your things. So thanks a lot for your time. Thanks.
Thank you, Dr. Suhail. Now I request Dr. Zahid Ashraf to please felicitate Dr. Suhail Parvez with a memento and a flower. Ah, all may please join. Yes, ma'am. Yes, ma'am. With this, we move forward to our next talk. We have Professor Kavita Gulati, Department of Pharmacology, VPCI, University of Delhi, and she will be delivering her talk on interaction of traditional and modern medicine during drug-induced hepatotoxicity.
Again, before she reaches the dais, she is among very eminent pharmacologists in the country, and she has done some exceptional work on the hepatology. So we all should get what do you say, enrichment, not only in terms of knowledge, but if you want to do any kind of experiment, she is always very supportive. So anyone who is interested in doing testing, understanding anything related to liver should approach her, and then since because of time, I don't want to get in further to her research. Ma'am, dice is yours.
Thank you so much, Chairman Sir, and for your kind words. And I'm also very thankful to the CCRUM for giving me the opportunity to share my research experience and to present the interaction of traditional and modern medicine during drug-induced hepatotoxicity. So we all know that, next slide, please. So we all know that what is the traditional medicine. So traditional medicine is the one which has come from since ages, from the word of mouth. We have given the knowledge to each other. So it is the skill and practices based on the experiences indigenous to different cultures and different philosophy, and it differs from the philosophy of the modern medicine. So we have the traditional system medicine like Ayurveda, Unani, homeopathy, Siddha. So according to a WHO report, more than 75% of the developing world's population is believing and relying on the traditional medicine. So now the government is also focusing on the, like he has mentioned, the repurposing and developing more of the drugs, the new drug development from the traditional medicine. Next, please. Next, please. So the interaction or the translation of the traditional medicine we can can get by two ways. That is the translational medicine, in which we do first the cellular and molecular studies, the pharmacodynamics, toxodynamic studies in the lab. And after it is approved, we submit all the data to Drug Controller General of India and try it in the patients. And other approach is the reverse pharmacology. That is what we do with the traditional medicine, in which the drug is already being given in the traditional clinics like Unani clinics, and when it is already given and like it is being used from hundreds of years, so then taking it to the labs to explain how it is affecting, so to validate their effects and to bring it near to the modern medicine. And we were working on the integration of traditional and modern medicine. So the concepts of classical pharmacology and cellular molecular biology are being incorporated for the drug development from the traditional medicine. Next, please. So I will be discussing this integration of the two systems with reference to the hepatotoxicity. We know that liver plays a very important role in metabolism and elimination of drugs, xenobiotics. So during that process, it is exposed, it is vulnerable to the side effects of the drugs. And we are very well aware that hepatotoxicity in response to the anti-tubercular therapy is a big clinical challenge, because they feel when they get corrected by curate by the drugs, they start having the hepatotoxic symptoms, so they stop taking the medicine and it affects the compliance of the drugs, which results in the XDR-TB, MDR-TB. So it is one of the very biggest problem of our country to manage the anti-TB patients, but we don't have much good drugs to tackle this hepatotoxicity problem of this drugs, anti-TB drugs. Next, please. And another drug is the paracetamol. We know the paracetamol is, we like say that it is a very safe drug, but we also know that in higher doses it produces hepatotoxicity because of a molecule it produces, that is an acetyl p-benzoquinone imine. In the normal cases, when we are taking the normal doses of paracetamol and we have the liver functions all right, it is taken by the, it is tackled by the GSH, that is reduced glutathione, and it mitigates its negative effects on the liver. But when the rate of absorption is more than the rate of elimination, we start getting the hepatotoxicity. You know, some of the drugs, very good drugs, nimusulide, that's why it is banned for the children under the 12 years of age when the liver functions are not that developed. So these are the very common drugs which we face the hepatotoxicity in response to them. So in the absence of any authentic hepatoprotective drug in modern medicine, there is a need for search from alternative medicine. Next, please. So in traditional system medicine, especially in Unani system, we have many formulations which are effective against the hepatotoxicity. So there is one formulation, Dawa ul Kurkum, which is used in cases of liver dysfunction, anorexia, ascites, and abdominal pain. So we did a collaborative study with the CCRUM to evaluate its effect and to find out what are the cellular and molecular mechanism, how it is acting. So I will give the real experience of the research with the and the integration of the traditional and modern medicine. Next, please.
So we aimed at finding its efficacy, safety, because we know if a drug is efficacious. In the morning only, I heard in the one of the lecture that only the efficacy is not important. That's just replacing one effective drug with another one. But the safety is more important than the efficacy. So we did the 90 days subchronic toxicity studies as per the OECD guidelines, and because we tapped all the factors which are responsible for hepatotoxicity. We know when some drug is affecting the hepatic functions. We did all the macro studies, micro studies, liver function test, histopathology of the tissue, how it's producing the effects, inflammatory markers, cytokines levels, interleukins, as well as the immunomodulatory effects. Because we know the drug which is producing the hepatic dysfunction is affecting the immune functions. So we looked into all these parameters. Next slide, please. Next, please. So this is the drug Dawa ul Kurkum, which has the 9 ingredient, and it is the standardized preparation which we got from the CRUM, Central Research Institute of Unani Medicine, Hyderabad. They provided the standardized preparation. Next, please. So in the for inducing the hepatotoxicity, we gave the high doses of the paracetamol or the antitubercular drugs, that is pyrazinamide, isoniazid, and rifampicin for 28 days orally to the animals. And for paracetamol studies in the different model, we use it in 2 gram per kg of the dose for about 14 days. And we treated these animals daily for 28 or 14 days with the Dawa ul Kurkum and found what are the results. Next, please. Next, please. So these are all the biochemical tests we performed. We in immunomodulation, we performed both adaptive immunity, like we studied the humoral immune response by measuring the different immunoglobulins in serum, and we also did the cell-mediated immune response, that is the delayed type of hypersensitivity reaction, in which the animals are immunized and they are challenged on 14 day, and the swelling in the plantar surface is recorded by the plethysmograph, and that how much inflammation it is producing. So these were the different methodology, like he has already, the chairperson said, anybody wants to have those methodology can contact me. My email is there, and we can how to standardize those procedures. Next slide, please. Next. So these are the various parameters we have studied. Next, please. So now we come to the results part. The table shows. Next, please. The table shows the effect of, I think it's visible to all the results. So when we gave the experimental control, that is the animals which were given the anti-tubercular drugs daily orally for 28 days, there was less increase in the body weight, because when the hepatic functions are disturbed, the weight gain was not there, and liver weight was increased, which was because of the inflammation, and the liver index, that is a ratio of liver weight to the body weight, was increased. So when the Dawa ul Kurkum was given in the doses of 250 milligram per kg and 500 milligram per kg, which was equal to the clinical dose which is being given in the Unani clinics for hepatoprotective effects. So it reduced and attenuated those damaging effect of the anti-tubercular drugs. Next, please. So as you know, for hepatic function, the liver function test is very important to assess how it is functioning. So we see that SGOT, SGPT, ALP levels were increased in the experimental animals which were given the anti-TB drugs. And silymarin, which is a standard drug, which is now being given along with these drugs. But it is also not approved by the FDA. But it has good amount of data, and this we take as the standard, was reducing this liver dysfunction, and the results we got with Dawa ul Kurkum was even better than the silymarin. Next, please. So then we come to the immunomodulation, and we see that there was increased the immunoglobulin response in the animals who were given the anti-tubercular drugs. And when silymarin was given and the Dawa ul Kurkum was given, there was reduction in all the immunoglobulin levels. As we know that immunoglobulin M is the first one, which is the primary antibody response to the adaptive response. So IgG, when the situation is growing from the acute to chronic stage, it was also increased, which was reverted back towards normalcy with the treatment with the Dawa ul Kurkum. So again, the study showed that Dawa ul Kurkum is playing an important role in the immunomodulation, which is happening during the hepatoprotection. Next, please. Then we come to the cytokines, actually the cellular level and molecular level, that what are the things which are being affected actually. So the interleukins which are released from the Th1 cells and the Th2 cells, that is IL-13 and IL-4 from the Th2 cells, they were also increased, and which was reduced by the silymarin and the dawa ul kurkum. So interferon gamma, which is released from Th1 cells and as a mediator of the cell mediated immunity, was also increased, and which was reverted back towards normal by the dawa ul kurkum. Next, please. This is the DTH response. When the delayed type hypersensitivity was measured, there was reduction in the experimental animals, which was reverted towards normalcy by the dawa ul kurkum, and the results were comparable with the silymarin, which is well accepted drug in the medicine. Next, please. Then we thought, because always whenever the inflammation is there, there is imbalance between the pro-oxidant and the antioxidant factors. So we measured the various markers of oxidative and nitrosative stress, because when the free radicals are generated, they react with the peroxinite, they form the peroxynitrite radicals, which are further damaging. So we measured the stable metabolites of nitric oxide, and we found that there was a significant increase in the stable metabolites of nitric oxide during the ATT-induced hepatotoxicity, which was reduced by the dawa ul kurkum. And similarly, the MDA, which is a marker of the lipid peroxidation, which is done by the damage to the lipids of the hepatocytes lipidic layer by the hydroxyl peroxyl radical. So it was also increased significantly in experimental control animals, which was attenuated by the treatment with dawa ul kurkum. And GSH, that is a reduced glutathione, which is a marker of antioxidant, which was reduced in the experimental animal, was also brought back to the normal levels. Next, please. So this all data, macro level, all the liver function tests, anti-inflammatory, was supported by the histopathological studies. And we see the damage degeneration in hepatocytes, which happened in the experimental control group, was not seen in the animals which were given the dawa ul kurkum, and the results were comparable with the silymarin. So it proves that yes, truly there was a change in the histopathology of the cells. There was hepatocytes were more maintained, and they appeared normal after the treatment with these drugs. Next, please. So then we moved on to the paracetamol. Did a new study in which the paracetamol, again a very commonly used drug, was given, and we found that the similar kind of results were obtained, that there was decrease in the body change. So it further corroborates and like it validates the standardized model that the similar kind of results were obtained with the paracetamol as well, when it was given in the dose of 2 gram per kg for 14 days. And the liver index, which was increased, was also returned back towards normalcy by giving the dawa ul kurkum. Next, please. Similarly, liver function test. Next, please. And the immunoglobulin levels, that is immunomodulation, was also observed. There was increased the immune response to the drugs xenobiotics by this paracetamol, which was reverted back towards normal, or we can say the changes were attenuated by the dawa ul kurkum. And again, the results were, some of the results were in higher doses were better than the silymarin. So it was very interesting that in some of the parameters, the results obtained were better than the silymarin drugs, which is well accepted in the even in the modern system. Next, please. Similarly, the results of the interleukins corroborated the earlier findings that the drug has strong anti-inflammatory effects and on the hepatocytes. Next. Similarly, the DTH response was reduced and it was brought to normal by the treatment with the dawa ul kurkum for 14 days. Next, please. Again, interestingly, there was an imbalance between pro-oxidant and antioxidant, and there was increase in the levels of reduced glutathione and reduction in the MDA and the stable metabolites of nitric oxide. We say that because nitric oxide now is becoming a very popular molecule, and it is almost in all the organ systems. So its levels are depending on the kind of nitric oxide which is being produced, because some of the constituted type of nitric oxide is very helpful for our body, maintaining the cardiovascular system, neural system, plasticity, and all. But when its level cross one level, the inducible nitric oxide is stimulated, which is responsible for the damaging effects. So we have to maintain the levels of the nitric oxide within a limit. It should be the optimum level, neither too low or the too high. So these levels were maintained by the Dawa ul Kulkum. Next, please. Histopathological findings further confirmed that the hepatocytes were normal, the lobular structure was towards the normal, and it protected the anatomical features of the hepatic tissue also. Next. So after that, as I mentioned, that besides efficacy, we have to also focus on the safety. For safety, the subchronic toxicity study was given. First, we did the limit test in which the drug was given in a very high dose, Dawal Kurkum, in 200 milligram per 2000 milligram per kg, and it was found to be very safe in that dose. After that, we did the subchronic toxicity in which we gave the drug orally to the animals for 90 days together in 250 and the 500 milligram per kg. And we found when the drug was given to the normal healthy rats, it was not affecting the liver functions at all. All the levels of the enzymes were well maintained and they were comparable with the control animals. Next, please. Similarly, the total bilirubin, all the liver functions were well maintained by giving the Dawa ul Kurkum as well as the hydroalcoholic extract of Dawa ul Kurkum. Next. Oxidative parameters were well maintained, although there was some increase in the reduced glutathione and reduction in the MDA levels, but it was not significantly different from the controls. So again, he's saying that it does not affect the parameters in the normal physiological conditions. Next, please. Similarly, the initial body weight and all these were well gained. The animal was improving and getting the weight. The growth was okay. Next. So these are the histopathological examination. Next, these are the control slides. The control for comparison with the Dawal Kurkum slides. Next, please. So this is a normal architecture of the tissues, ovary, spleen, stomach. So all the histopathology of all the organs of the control animals. Next. And the animals treated with Dawal Kurkum was given. And it again showed that 90 days of treatment with this drug, hepatic tissue appeared normal and there was no degenerative lesions were seen. Heart also, most of the cardiac tissues appeared normal. Kidney was normal. No degenerative changes are there. So all the organs, the histopathology of all the organs showed that there was normal architecture of these organs. Next, please. So all the tissues, because you know in subchronic toxicity or OECD guidelines, you are supposed to do all these studies, histopathological studies, as well as the neurobehavioral, observing the animals daily, how much weight they get, piloerection. So these all the things you have to observe daily. Next, please. Next, so all the organs were showing the normal structure. Next. Next. So we can summarize that the administration of Unani polyherbal Dawal Kurkum with anti-tubercular drug significantly prevented the rise in the levels of immunoglobulins and cytokines. It brought back the liver function test, which was affected as evident from the SGOT, SGPT levels. And it also had the differential effects on the cellular immune responses and the delayed type hypersensitivity response. So this all these results together shows that it targets at all the places, at an inflammation, at oxidant pro-oxidant balance, and brings back the hepatocytes towards the normal as evident by the histopathology. So the result shows that it is a good hepatoprotective drug which can be given along with the anti-tubercular drugs to tackle the problem of poor compliance and the MDR-TB and the XDR-TB. Similarly, the protective effect was proved by all these parameters in the paracetamol-induced model of hepatotoxicity. Next, please. Yes, next, please. So the protective effect can be because mainly the free radicals are the disease causing particles. So it is targeting the root cause by reducing those free radicals and increasing the antioxidants. So as during any drug development, safety is more, we have done that. Next, please. So we can conclude that these drugs, as we are aware, the paracetamol and antitubercular drugs cause hepatotoxicity, and which is reduced by the treatment with dawa kurkum. And it was found to be effective against all the above xenobiotic induced hepatotoxicity, thus validating the hepatoprotective effect against using modern scientific technology. So it has no adverse effect as per the OECD guidelines 408 we used. And subtranslation. So such translational studies in which the drugs which are being given in the Unani clinic and doing all these parameters, the modern scientific parameters, and validating their effects and delineating their mechanisms can bring back and integrate these drugs with the modern medicine. So because of the success of this protocol, this project, I have been offered a clinical project to do actually now in the patients, to do the patients who are the tuberculosis patient and give dawa ul kurkum along with that to see that how they behave and how the hepatoprotection effect is observed with this drug. So soon we'll be starting in the clinically in patients as well. Next, please. So these are the publications which we have done from this project work. Next. So I'm very thankful to Ministry of Ayush, CCRUM, for funding this project, for this collaborative work, and Professor Ere, who is the co-investigator in this project, and Professor Rajkumar, who is director of the institute for providing all the facilities, and Mohammad Rafi Reshi, who has done the PhD in this project and a very sincere student. So thank you so much. Any question? Any question?
Thank you so much, ma'am, for your talk. I now request Dr. Ishtiaq Ahmed to please present a memento and flower. Dr. Mushtaq, Dr. Zaid, and Dr. Rashid, please join me also. Please, yeah, please join. And because when we have so many eminents together, so why to miss anybody? Yes. Moving to the last talk of this session, we have with us Professor Arshia Sultana, a professor from National Institute of Unani Medicine, Bengaluru. She will be delivering her talk on role of Unani medicine in reproductive health of women, with special emphasis to diabetes.
Hello. In the name of Allah, the most beneficent and the most merciful. Assalamu alaikum and a very good afternoon to all of you. At the outset, I'd like to thank the organizer, CCRM and Minister of Ayush for giving this opportunity, respected dignitaries on the dais and off the dais and their delegates. Today my talk is on role of Unani medicine in women's reproductive health with diabetes. I'm very lucky and privileged that in this today's session, it was a multidisciplinary session where I've given this opportunity. Next. Like learning objective is what? Is diabetes a public health problem? What is the relation between reproductive health and diabetes in women? What is the concept of diabetes in Unani medicine and management of diabetes mellitus in Unani medicine? Next. So, as we have seen that the diabetes has become a public health problem, and it was first declared as a public health problem in 1970s. That means already we have completed more than 40 years. With diabetes and pre-diabetic continuing to grow at unprecedented rates, therefore addressing diabetes as a public health concern is even more important today. Next. Here we see that a public health approach to diabetes is a broad, multidisciplinary perspectives that is concerned with improving outcomes in all people who have diabetes, with attention to equity and the most efficient use of resources in ways that enhance patients and community quality of life. For the people with diabetes, medical issues are not the only area that requires management, but we see that lifestyle, family, psychosocial, cultural, and economic issues are also important for diabetic patients. Next. Then again, we say that diabetes mellitus is not only a local public health emergency, but it is a global health emergency. And we are seeing that around at 2040, we can see that more than 642 million people will be suffering from diabetes. And here, diabetes itself is not uh, having problem, but we see that diabetes along with other comorbidities are having more risk. Though such complications, diabetes may kill 5 million people annually worldwide, and most of them will be prematurely. Next. So here we see that now that the diabetes has become a public health issue for 21st century, and we are seeing that it has become the seventh leading cause of death worldwide. And it is not only a medical problem, but it has become a social problem also. And it has become a worldwide epidemic. Like we are seeing as a COVID like epidemic, diabetes has also become an epidemic disease now. Next. So here, as we all know, what is diabetes? The term, it's a Greek term which means to run through or passing through. It has been given many other names like Dulab, Zilukhul Kulia, etc. Next. And we see that the symptoms which has been mentioned in conventional medicine, that is polydipsia, polyuria, polyphagia, and loss of weight, the same symptoms are also said in the Unani text. Next. Here, then it is classified according to the presence of sugar in the urine and according to kefiyat and shiddat. According to the absence of sugar in the urine or presence, it is diabetes, ghair shakari or shakari, and according to kefiyat and shiddat, it may be har or barid. Next. Then the causative factors are it can be renal insufficiency, it can be sue mizaji gurda, heart, barid, or it can be other causes as well. Next. So we can see that when we were studying our undergraduates, we used to study in Sharia Asbab that diabetes can be caused because of involvement of liver, pancreas, kidney. That time we used to think, we have studied that only pancreas are involved for diabetes. But go back. But when I have gone through this slide, I came to know that really hyperglycemia is not only affecting the pancreas, or only the pancreas are not involved in hyperglycemia. We see that other organs of the body are also important in causing hyperglycemia. For example, liver, kidney. Just now I said that Unani concept said that the kidney is having role in hyperglycemia. The same concept is seen in conventional medicine where they say that not only pancreas but guts, kidney, liver, skeletal muscles, adipose tissue and brain are also important in causing hyperglycemia. Next. Then come to actual topic that what is reproductive health in women. Reproductive health is a state of complete physical, mental and social well-being and not merely the absence of disease or infirmity. And it addresses the reproductive process functions and system at all stages of life. Next. So here we say that diabetes is a serious public health concern, severe and neglected threat to reproductive health, and there is rise in the incidence of diabetes too in women of reproductive age. Especially, the reproductive journey of a woman is very complex, which starts with menarche and ends at menopause. For women with diabetes, this journey can be difficult with reproductive abnormalities at every stage. Just now I said you that the reproductive age includes from menarche to menopause and it can affect the woman at any time. So not only the diabetes mellitus is having high morbidity, we see that high blood pressure is also having high morbidity in causing reproductive health. Next. Then here, it is predicted that in 2030, it may affect 79.4 million women in India. And we see that the diabetes mellitus is not a single entity, but it is multifactorial, involving genetics also. And we see that because of changes in lifestyle, obesity, urban migration, and lifestyle changes may lead to diabetes mellitus. Next. So here, what is a reproductive dysfunction seen in a woman because of diabetes? It can cause delayed puberty, delayed menarche, menstrual cycle abnormalities, subfertility, adverse pregnancy outcome, and early menopause. So you can see that there are array of dysfunctions which can be seen because of diabetes, and they are saying that diabetes, type 1 diabetes mellitus, can also cause primary amenorrhea. Next. Next. So here we can see that reproductive health in diabetes women, we can see that it is not only affecting the menstrual disorders, but it also has effect on sexual dysfunctions like hyperactive sexual desire disorders, depressive disorders, polycystic ovarian disease, and they are saying that it may predispose to cancer also. And not only that, it also causes dyspareunia and other dysfunctions. So here we can see that uncontrolled or long-term diabetes mellitus is, it causes oxidative stress as well as it has effect on the vascular system of the body, thereby causing dearrangement in the whole body. Next. Then again, as we all know that in Unani concept, Ethebase thumbs or amenorrhea is caused because of velcomatic temperament or sway misaj barit, which causes weakness to the liver, leading to amenorrhea. Like that, Razi also said that the involvement of liver to cause Ethebase thumbs is similar, saying that we can see that polycystic ovarian disease, we are giving insulin uh, uh, because there is a insulin resistant in polycystic ovarian disease cases, saying that there is increase in the hyperglycemia, or polycystic ovarian disease is having hyperglycemia also. So they say that there is involvement of liver in the cases. Next. So diabetes influences contraceptive choice, pregnancy and menopause. And during pregnancy, we see that diabetes not only affects the mother, but it also affects the fetus. Next. So here, pregnancy and diabetes, we can see that the diabetes is not only affecting a reproductive life of a woman, but it also has effect on the pregnancy and its outcome. Next. So we can see what is the risk factors for diabetes during pregnancy. It may cause fetal risk as well as maternal risk. Fetal risk are spontaneous abortion, intrauterine death, and stillbirth. And it can cause congenital malformations as well as big babies, causing shoulder dystocia and birth injuries. It may cause neonatal hypoglycemia and respiratory distress syndrome. What are the maternal effect of diabetes on pregnancy is it can cause hydramnios, preeclampsia, PIH, retinopathy, obstructed labor, assisted delivery, and cesarean section, and also infections. So we see that the diabetes is not only having effect in a reproductive health, but on the pregnancy, both on fetus and mother. So maternal, next, uncontrolled diabetes mother, that is pre-existing uh, diabetes, can also affect the baby, and it is said that around 4 to 8 times more chances to develop diabetes in later life. That means if the mother is having diabetes mellitus during pregnancy or gestational diabetes, the fetus is having 4 to 8 times more chances to get diabetes. So this is the correct time that we should be aware that it can be prevented. If you want, we can prevent diabetes by following a healthy lifestyle. This shows that environment in the uterine life contributes significantly to higher risk than to be explained by genetic inheritance alone. Body mass index greater than 30, a history of unexplained fetal demise, having delivered an infant weighing more than 9 pounds, family history of diabetes, all these are predisposing factor to develop type 2 diabetes mellitus after GDM. Next. So I will not go on this slide. Everyone knows this slide. Next. So management, as we know, diabetes is a complicated disease. Hence, the treatment is also very complicated. Next. So according to Unani concept, because there is dearrangement in the temperament or there is sway misaj, therefore we have to correct the sway misaj and remove the predisposing factors like change in lifestyle, diet change, etc. Next. So here, there, as we all know, the mode of treatment in Unani medicine is not only the Adivya or pharmacotherapy. We see that the mode of, thank you. So mode of treatment is lifestyle changes like physical exercises, avoiding excessive sleep. Especially what I have read that after Fajr, Asr and Maghrib, we should not sleep. And it is showing that nowadays we see that young generation, they usually sleep at this time, morning, evening, and in between Asar to Maghrib. So this time we should avoid sleeping because excessive sleep is causing more diseases like polycystic ovarian disease, which is again a predisposing factor for diabetes mellitus in later life. Stress, strain, anxiety should be avoided. Avoid sedentary lifestyle. Avoid refined cereals, then irritable giza. Give more weightage to fibrous food. Avoid fighter food. I think so. You people all know all these things. I will not go more in detail. Then again, the treatment like diet, methi, palak, all the simple things what is available in our house is also having anti-diabetic effect which can be used in the daily household. Then I'm not skipping because of paucity of time. For reproductive age women with impaired fasting glucose tolerance, lifestyle changes is an effective tool to diminish the insulin resistance related diseases. So nowadays, what we do if the patient is pregnant and she is having GDM, initial stages, we don't advise any medication. We just say change the lifestyle and diet modification. So medical nutritional therapy and lifestyle changes as a component of daily this nowadays they are saying daily self monitoring of the diabetes is a positive effect on psychosocial and behavioral aspect of diabetes. So just now I said lifestyle intervention was more effective than metformin. A study has said that exercise and weight loss may improve vascular endothelial functions, and lifestyle modification consistent of moderate diet, minimum of 7% of weight loss, and 150 minutes of aerobic exercise each week. So these studies say that lifestyle modification is having role in controlling diabetes mellitus. Again, this already I said that nowadays they are saying we can go for self monitoring of the sugar. It is self monitoring education given to the patient how to monitor the diabetes mellitus at home, and we can take care of ourselves. Smaller and more frequent meal results in lower glycemic loads and decreased endogenous insulin required. The same concept has been said in Unani medicine that takes smaller and more frequent meals. The quantity and glycemic index of carbohydrates consumed limited and combined with concurrent ingestion of water and a protein choice. Carbohydrates are found in many fruits. I will not go in detail. So, eligible dawa. Here I like to say that in menstrual irregularities, we don't have to go for new drugs. Whatever drugs we are using as a mudiri has, the same drug also has anti-diabetic effect. For example, if you see methi, darchini, all these drugs are already proven for their this anti-hypoglycemic effect. So we don't have to go for a new drug like Sharbati Afsandin, Filfiladaras. All these drugs are already proven to have this oral hypoglycemic activity. Then in menorrhagia also, we can give the same drugs because again these drugs are having oral hypoglycemic activity. So these are the formulations also which can be given in a reproductive age. Same formulations can be given in a reproductive age woman which are given in normal person also. So various Unani drugs exhibit anti-diabetic activity, nototropic activity, antioxidant and immunomodular activity. The good part of Unani medicine is that our medicine is not only having a simple single effect, but it has multiple effects. Like just now I said, it is having antioxidant as well as immunomodular activity. So whatever drug we are taking, it's not having a single effect. Among the possible mechanism of action, we see that it inhibits alpha glucosidase, alpha amylase, and the effect on glucose uptake and glucose transportase. So it is having multiple effects. So here we can see that there are some medicines which are proven to have anti-diabetic effect in vitro and in vivo studies. So I'm not going in detail. Like neem, it inhibits alpha amylase and alpha glucosidase. Like again, you can see Karela, Methi, Jamun. I have selected those medicines here which are easily available and which are used daily at home. Darchini, Alsi, and Zanjabil. All these drugs are having oral hypoglycemic effect. Take home message: diabetes mellitus is a condition that should be treated aggressively, as uncontrolled cases can result in detrimental effect on reproductive health of women. In control, patients with diabetes mellitus experiences a relatively healthy life. That means diabetes mellitus can be controlled if we follow a healthy lifestyle, diet, and medicine. As such, long-term health complication can be reduced. Maintain an ideal body weight. Following a healthy diet, exercising will reduce the risk of developing type 2 diabetes. Conclusion: the Unani medicine has a remarkable scope in comprehensive management of reproductive health in diabetic women. Hence, physicians need to understand how diabetes affects women's reproductive health and to provide appropriate prevention and treatment to improve women's quality of life. With this, thank you.
Thank you, Dr. Arshia, for that presentation. Now I request the Chairperson, Dr. Mushtaq Saab, and Dr. Zahid Ashraf to please felicitate Dr. Arshia with a memento and a flower. The co-chairs also may please join. Please, ma'am. Please, please. Okay, thank you. We'll have एक minute group photograph के लिए sir अभी. I request the chairpersons to please present with the concluding remarks. The section. सर नमाज तो निकल ही गई है. Section ही पूछ.
Thank you so much to all the speakers to by and large sticking to the point, and it was a wonderful session. And as I said in the beginning itself, we had two people from, I would say, not, I mean, Unani is also modern, but I say that molecular background, and then one was a clinician and other was the basic scientist. So you have doctors from Unani as well as the basic researcher from Unani. So this has been a wonderful session where you have all kinds of people in four, and then I must appreciate organizers to put in this kind of all flowers in one basket. So the take-home message from these all, I will not get into technicality, but I would say that one has to somehow or other know we have invited good people from the modern science or molecular biology background or the clinical research background. Their services should be more extensively used for the betterment of conventional medicine. And other way around, conventional medicine has also its own challenges and its own potential. So I would urge the moderns and molecular biologists per se to look into, to come forward, to understand the mechanism. And these medications or these formulations are there for ages, there has to be some basis. And the basis is much more, I would say, is strong, much more robust, because it's going on for centuries, 200, 300, 400 years. And if you look into their manuscripts, you look into their literature, Chinese have done exceptional work by looking into, again, not to deviate or elongate from you, but those who want to look into, they can follow the amazing Chinese medicine. Example, TCM has done phenomenal job in terms of understanding the modern disease and analyzing their polyherbal composition. What we intend to do, somehow try to prove that what is active component, what is the individual component, so Chinese have not done this. Chinese have done other way around. They have not touched the integrity of the herbal medicine or Chinese herbal medications. So somehow, and they have shown that yes, the modern tools could be used to keeping their composition, their preposition, or their component, or their forms intact. I think I'll just wrap it here, is that if you really want to look into, please try to look into Chinese strategy. They have done a phenomenal job by correlating these polyherbal composition for disease. So let's see if somebody has 1, 2, 3 polyherbal combinations and it is involved in XYZ disease. So they have neither digged into disease, neither they have disturbed their polyherbal formulation. What they have done is that they have created a network. So somewhat, if I'll get in future sometime and we tend to interact with you, we'll try to explain their strategy. But if you really want to excel, I would request all of you to please look forward to their model. Thank you all, and sorry for taking extra time, but either way, we are just there for the betterment of science and betterment of knowledge, sharing the knowledge. Then over to you, Mustafa.
Now, I'm not going to take much time. Only one thing I say. This is the need of the time to better understand the merits of Unani system of medicine. It has a lot of merits, but they have not been understood in the manner they should be. To understand them through the prism of science, and then to disseminate that knowledge at the global level so that nobody remains unaffected and unmerited by United States. That's all. Thank you.
Thank you so much, sir. Both of you raised the point actually right on the dot that we need to work in integration together and following the best module. I think TCM is the best module available today to the for alternative and complementary medicine. Coming to the felicitations for our chairpersons. Uh, it's always a privilege to have such galaxy of eminence to be present amongst us. So I would like to request Dr. Zahid Ashraf to please present a memento and a flower to our chairperson, Dr. Mushtaq Ahmed sir. Hmm.
That would be like some honor to. Thanks. Pleasure to be with you, sir.
Kind of you.
Coming from you, sir, I'll take the privilege to present a memento to you. Now I request Professor Mushtaq Ahmed sir to please present a memento to Dr. Ishtiyaq Alam sir, Deputy Director, RIM Patna. Dr. Ishtiyaq Alam, please present a memento to Dr. Ishtiyaq. He is the in charge of our Regional Research Institute of Unani Medicine at Bhadrak.
He is the youngest.
Youngest in charge, actually. Yes, we can.
एक मेरा भी ले
इस ग्रुप के
बस वो अरे वो पहले हमारे से कर दो, छोटे से हो जाएगा फिर लॉक ही हो जाएगा।
फोटोग्राफ में जो सर के सही
इधर आ गया।
ये हमारी रिपोर्ट है ये चीज डॉक्टर सराना उमर
वंडरफुल
पेपर
हाँ
का पेपर दिखा रहे थे डॉक्टर
माशाल्लाह।
ये SRF है
आपको व्हाट्सएप भी ले
हाँ
थैंक यू सो मच।
Thank you to all. Now we will break for lunch and then join together for the next session. आपको बात करनी पड़ेगी। Sir, what is your
इसमें आपका मोमेंट
शुभस्ता नाम बीच में डाल। हाँ ये चीजें अब सुनो इधर डालो कोचेस रूम इधर डालिए यहाँ सुबह पे ऐसे ना यहाँ देखो कोचेस वहाँ पे कैसे बताइए आप नहीं इधर जो बैठते हैं ना इधर नहीं वो ठीक जो चेयर होते हैं वो हाँ नहीं आता है कोई शुगुफ्ता मैडम को बीच में डालो चेयर ये ला लेते हैं हमारे रबर चेयर्स का चाव ले लेते हैं शुगुफ्ता मैडम बीच में डालिए
मैडम तो अभी कॉल किया ना मैडम तो लिंक चाहिए की बात क्या बात है ये अरे भाई साहब क्या बोलेंगे 12 बजे बोलेंगे हमारी आपसे मेरी बात हो गई मैडम क्या बात
नहीं एक कम पड़ एक कम
ये खाने क्या
नहीं आएंगे एक आपको बोलना क्या प्रोवाइड करेगा आप प्रोवाइड करोगे तो नीचे जाना पड़ेगा कौन करेगा बेटा बोलो हो गया शायद हो गया हाँ आपके पास
them with us. So I request our co-chair, Dr. Mohammad Nafis Khan sir. He's the Deputy Director, CRIUM Lucknow, to kindly grace this podium, chair, sorry. And I also request Dr. Shirin Afza ma'am, Research Officer Unani in charge, RRIUM Aligarh, to kindly grace the stage. This session is on non-communicable diseases, a challenge to combat. We will be having 4 speakers, and I guess one of our speakers is still missing. So since we are already late, I'd request the first speaker, Professor Alpana Sharma ma'am, Department of Biochemistry, All India Institute of Medical Sciences, New Delhi, to kindly tell us about, give your deliberation. Alpana ma'am.
So, good afternoon, everybody. So, I am going to talk about Itrophaly of the moon as plausible adjuvant therapy for chronic myeloid leukemia, a complementary integrative approach. So, little bit introduction about CML. So, chronic myeloid leukemia is very far off and a small screen, so I am not able to read it properly. So, sorry, I will be focusing this side. So, CML is a myeloproliferative disorder resulting in the accumulation of granulocytes or monocytes in the bone marrow. So, there is a defect in the bone marrow where the accumulation of granulocytes and monocytes takes place. It accounts for approximately 10 to 15% of all leukemias worldwide, whereas in India, it is one of the commonest adult leukemia, accounting for approximately 50% of all adult leukemias. So, what is the pathophysiology? Where is the defect in this cancer? This is the first cancer to have a specific genetic link to a chromosomal mutation which is identified for this CML. It is known as Philadelphia chromosome because there is a translocation or genetic mutation between chromosome number 9 and 22. ABL, or the Abelson, the name of scientist, on chromosome number 9 is translocated to chromosome number 22. Sorry. How to बीच वाला pointer और next से चलेगा, point out नहीं कर सकते हैं center वाला ना okay चल रहा है no it's not working छोटा से गड़बड़ होगा okay so on the chromosome number 9 we have ABL gene. On the chromosome number 22, we have BCR gene. And in this, there is a translocation where the ABL gene goes and fuse with, translocate with the, on the 22 chromosome and form the ABL BCR gene. And this is translated into ABL BCR protein, which is an unregulated tyrosine kinase and thus produces immature granulocytes. What is the treatment for this disease? We know this chemotherapeutic drug imatinib, which is a tyrosine kinase inhibitor, because defect is in tyrosine kinase. It is currently employed for the management of CML, and the drug causes several side effects apart from having the benefit to the patient. So, what are the side effects? There is severe fluid retention resulting in swelling, may cause low blood counts, as happens with all the chemotherapy drugs, anemia, hemorrhage, and the vomiting, diarrhea, etc. So, what is the demand for today? In order to have safe and effective treatment regimen, adjuvant or anti-tumor property of Unani preparation could be explored. So in most of the chemotherapy, what happens? There are side effects. There are lack of effectiveness. Some chemotherapy are effective to particular cancer, others are not. Or chemo resistance. Initially, when you give drug, it is sensitizing the drug tumor, but after some time there is a chemo resistance, and morbidity is always there with the chemotherapeutic drugs. So there is a necessity to identify an efficient, less toxic, and cost effective treatment modality for cancer therapeutics. Herbal medications, as it is going on since morning, we all know, are there in the Indian system of medicine, which provides promising option for cancer treatment as an alternative or adjuvant therapy. Today I am going to talk about Itriphalia of the moon. Itrifal is Triphala. It is a mixture of three components of native Indian subcontinent, which includes amla, harad, and bahira. It is known for its antioxidant property and used for treating stomach ailments and for other and body detoxification. Whereas of the moon, it is employed to treat complaints affecting the kidneys, spleen, and different disorders of liver. We got this preparation from the CCRUM, and we came to know that it has some 14 components, out of which these three components, the amla, harad, vaheda, and the aftermoon, is in the maximum number percentage. So what is the lacuna in this study? There is no literature available for Itriphaly of the moon in any cancer, including CML. Its adjuvant or anti-tumor potential in CML has not yet been studied. So when we talk about any cancer, whether it's a CML or some other cancer, we know there are some certain hallmarks of cancer. These hallmarks like sustaining proliferative signaling, where these cancers, they may go through different signaling pathways, evade growth suppressor. We have some tumor suppressor genes like P53 and others. So they evade these growth suppressors. Avoiding immune destruction. They avoid the immune system and then it may cause inflammation. Enabling replicative immortality like telomerase activity, which is increased in this. Activating invasion and metastasis. We know these cancer, they can invade to other tissues and cause metastasis. And then inducing these angiogenesis, because in the environment, these cancer cells, they need the new vessel formation. So angiogenesis there. Resisting cell death, where anti-apoptosis markers may be increasing, and re-regulating the cellular energetics, where mitochondrial membrane potential can change. So when we got the LCMS based characterization of aqueous extracts of this Itriphaly of the moon, we came to know that the catechins have 100% relative intensity than other constituents. And we have like ascorbic acid 17.85, we have caffeic acid. When we have gone through the literature to the papers, we came to know that these all three components, they have very good antioxidant property and they have been studied in various cancers. So for this particular studies today, which I am going to talk, we have used two CML cell lines which have been procured from ATCC USA K562 and KU812. We have done studies in both the cell lines, but today I am presenting the results of K562 mainly. So what is our plan for this study? We have taken these leukemic cells and treated with Itriphaly of the moon alone or in combination with imatinib, which is the standard chemotherapeutic drug for CML. And then we have done different assays like MTT assay, cell cycle analysis, apoptosis, JC1 assay, antioxidant, angiogenesis, inflammation, and signaling pathways. So I am coming one by one to all. So cytotoxicity of leukemic cells after treatment with IEEE alone, on in combination the standard was done after 48 hours, and we have found the IC30 value, that is inhibitory concentration 30, and IC50, that is inhibitory concentration 50, and we have found later on that yes, when we have used the combination, the cytotoxicity, this is decreasing in this. So these are the pictures of the cell lines where I can just explain the plan. Like we have taken the control where the cells were not treated either with IEA or with the imatinib. Then we have used IEEE at IC30 concentration, at IC50 concentration, then only imatinib alone at 30 and 50 concentration, and then we have started different concentration or different combination of both, like 30-30, 30-50, 50-30, and 50-50. So these are the various combinations just to see that at what inhibitory concentration we have got the best results. The same we have used for other cell line, but I am talking about K562 today. So first of all, we have seen the effect of cell cycle on CML cells using propionine iodide staining. And we all know that we have the cell cycle where we have G0 to G1 to S to G2 and M phase. And then when we do this analysis by PI, we get this kind of peak: G0, G1 peak, S phase, and G2, M peak. So we have done this experiment, and then we have found that in this combination, when we have used the combination, the middle panel, this one, we have seen that the enhanced cytotoxicity, where is an increase in sub G0 G1 phase. This is a sub G0 G1 phase. G1 phase, and reduced cell division in leukemic cells when treated with combination of IEEE and imatinib. Then we have done the effect on apoptosis of cells using annexin 5 FITC PISA. We know in the normal cell we have the double layer leaflet of the plasma membrane. Then we have used annexin 5 FITC link, that is the fluorescent dye, and propionate iodide dye. So what happens in the normal cell, the phosphatidylserine residues are in the inner leaflet of the plasma membrane. But if there is an apoptosis, then this phosphatidylserine, it flips out to the upper layer leaflet, and there this annexin 5 can bind to that. If annexin 5 is binding to that, it is giving FITC green signal. But if there is a late stage of apoptosis, there is a degradation in the membrane, and now the propionate iodide, the red color, it can enter inside the cell. So now you can get the color of annexin 5 as well as the PI. So here you can see that effect of apoptosis of cells, annexin 5, increase apoptotic cells upon treatment with combination of IEA and imatinib in the leukemic cells. So there is increased apoptosis after using the combination than the alone. Then effect of treatment on mitochondrial membrane potential was also seen. The depolarization using JC1 dye, and we know in the healthy mitochondria we have these J aggregates in the red color, but in unhealthy mitochondria, these green color, the JC1 dye can go inside and it can show the shift from the red to green. And when we have done this, we have found that in the combination, in the lower panel, you can see the last bars are all two bars are green. So there is a decreased mitochondrial membrane potential or depolarization, which is shifting from red to green in leukemic cells upon treatment with combinatorial drugs. Then we have also done the Western blot imaging showing the effect of drug treatment on proliferation and apoptosis. For proliferation, we have used PCNA, proliferating cellular and nuclear antigen, and for apoptosis, BCL2, which is anti-apoptotic, and we have seen that both has been decreased after using the combination. This is not working well, that I'm not, yeah. I'm not able to concentrate. So in the next one, 5 minutes. Okay. Effect of treatment on oxidative stress, angiogenesis, and inflammation was seen again. So all these combination they have seen that when we have used the combination of 50-50 and 50-30, that it shows increased antioxidant expression with significant decrease in the inflammatory and angiogenesis marker upon combination treatment of leukemic cells with imatinib and IEA. Lastly, we have done the effect of treatment on multiple signaling pathways, which signaling pathway they are modulating. And to our surprise, we have seen that these both drugs or the combination of erythropoietin and the imatinib has really modulated all the signaling pathways. We have used four: the FAC, PFAC, PSTAT, PEAKT, and PERK. So multiple signaling pathways were downregulated upon combination treatment of these leukemic cells with IEA and imatinib. So how to summarize, or this is a graphical abstract where I can say that yes, erythropoietin and imatinib, when they are used in the combination to CML cells, they are modulating or downregulating the signaling pathway. For proliferation, cell cycle G0 G1 arrest is there, increased antioxidant capacity is there, increasing apoptosis is there, angiogenesis is decreasing, inflammation is decreasing, Th1 and Th2 response is also decreasing. So after this, in the cell line, we have done the pilot clinical trial of erythropoietin CML patient, where we have used two groups. One group which received standard drug imatinib only, and the other group received this the erythropoietin along with standard drug imatinib. And we have collected the samples before treatment and after 3 months of the treatment. And then we have done the VEGF, IL-6, ORAC assay, and few parameters for quality of life, where basic side effects of standard chemotherapy like vomiting, indigestion, headache, weakness were noted. And results are under analysis. So I'm not going to present now. Maybe in next meeting I'll present the clinical trial results. So this work, the erythropoietin potential imatinib induced anti-leukemic effect by influencing FAC, STAT, AKT, UX signaling pathway against chronic myeloid leukemia in vitro. And this work has been done by my PhD student Nidhi, who is here in the audience, and very good journal where we have published this work, impact factor around 4. And we have also worked from this Ayush EMR project on Habbe's gun, which has also been published in Journal of Herbal Medicine. We have worked in CML as well as in multiple myeloma, that is also a hematological malignancy, that has also been published. And not only Unani formulation, we have also used cinnamon extract earlier, because from last 1 decade we are working on herbal extracts. And noble combination tensionin 1 was also used with lenalidomide in multiple myeloma, and which is affecting telomerase activity and sheltering complex. So I want to summarize that for the first time, Unani herbal formulation has demonstrated its anti-tumor potential in vitro. Combination of erythropoietin with currently used chemotherapeutic drug imatinib showed enhanced cytotoxicity. Angiogenesis, inflammation, and oxidative stress were decreased upon treatment with this combination. Integrative therapy of this efficiently eliminates the need to use higher dose of imatinib. This is very important point, because when we use some drug, if it is lower dose, then chemo resistance will be less in the patients. So this has also been seen. This formulation might reduce the side effects of conventional drug and improve the quality of life to cancer patients. Further validation of erythropoietin in clinical trials would prove its therapeutic potential, which can be used in the patients. So I just want to conclude that herbal medicinal plants are being emerging as novel adjuvant therapeutic modality for treatment of cancer. Our study is the first to demonstrate the anti-cancer effects of erythropoietin on CML cells. These are pharmacologically safe and act as chemosensitizing agents for chemo-resistant cells. It means when you are using in patient large amount or more concentration of chemotherapy, which may create chemo resistance. But when you have adjuvant along with this chemotherapy, then it can sensitize the patients more in the chemo resistant cells. These results will provide the impetus for using herbal formulations as adjuvant therapies. So I just want to acknowledge my group, Professor Tulika Seth from hematology, who has given us patient for the clinical trial. And this is the group of my students. Nidhi has mainly done for this project, my PhD students and MSc students. Finally, thank you very much for patient hearing. I would be happy to take the questions. Yes.
Thank you, ma'am, for the wonderful presentation. I am Tausi from RRM Srinagar. Ma'am, I want to know whether you have used any normal cell line
Normal cell
experiments. Yeah, I mean non-cancer cell line.
that we have done earlier, but here we have used, because we are using combination, we were focusing on combination as an adjuvant therapy. So here the control was the CML cells, where we have not put any drug. So we have compared our experiments from the control cells. Mean, yes, they were CML cell line, not the normal cell lines, but we have not given any treatment to this.
So do you have seen earlier that there was no effect of this this aqueous extract of this
No, for this particular formulation we have not used.
You have not.
No, for this.
So I would, it would be better if we would have used the normal cell line to
One can
make
do
it.
that.
And ma'am, my second question is that why you have chosen the aqueous extract?
Because we have used the aqueous extract as well as alcoholic extracts also were used, but we have found good results in the aqueous extract. That's why we have like forwarded our experiment with the aqueous extracts only. And we have done LCMS also, where we have seen that some 14 components were there, where caffeic acid and these were very high. The relative entity of some of the antioxidant constituents are very high. So we have used the aqueous extracts.
Okay, ma'am,
Yes, sure.
Yes, ma'am. The clinical study you have chosen now, whose results you have not shown. So why you have chosen IL-6 for evaluation? What's
Inflammation, for
So-
inflammation.
so
So because when you are doing clinical trial, you cannot take their bone marrow samples. You just can take blood sample. And in the blood sample, we have seen inflammation. We have seen angiogenic marker like VEGF and angiopoietin 2.
So have you seen any change in the?
There are changes, but I will not disclose it now because it's a clinical trial. It has to be opened with all the faculty members who were involved with, and then we discuss, and then only we release the results of clinical trial. It's not easy.
Thank you, ma'am.
One
Any
more
other
question,
question?
ma'am. One more, ma'am.
Yes.
My colleague, I'm Yunus from RM Srinagar.
Yes.
My colleague, this is related bit to that aqueous extract, where you have shown LCMS analysis of aqueous extract. Myself being a chemist, a bit interested in that context only, not in clinical sense. So, just bit strange, bit baffling for me now. Catechin in 100%. So, just please throw some light how it is possible.
Because we have not done LCMS in our department, we have sent it outside for the LCMS analysis, and we have got this constituent with the standard drugs.
Now, I have no objection with regard to the
Okay,
analysis
okay.
of constituents,
So
but when we talk about now relative percentage, this is basically that is what I am getting. This is relative percentage of different constituents present.
relative
So,
intensity. They say.
Relative intensity. So, in my opinion, I don't think it can be 100% because there are other constituents present also there. So,
100 as compared to others, as compared relative. It is not absolute intensity. It is not absolute intensity. It is relative intensity as compared to other. So they must be having some standards where they were must be finding that this is 0, this is 100, this is 0 for this particular compound, and it is 36% in this relative intensity.
okay.
I'm in biochemistry, so I will not be able to explain more than this. Thank you. Anybody else?
Thank you. I'm sure we have an ocean with us, and everybody would like to gain more knowledge from her. But we have a time constraint, so I'm sorry. We'll take the questions later.
Thank you. Thank you very much. Thank you very much.
Yes, please.
Thank you, ma'am.
So now that
Thank for the
now
insight
that is much
of
correct now.
in the study. It was heartening to see how Aftimun synergized to demonstrate anti-cancerous effect. And thank you for encouraging your interest with your study and your interest. Thank you, ma'am. Still, ma'am, your interest is encouraging for us. Now I call upon Professor M. Shahryar sir. He's an associate professor in the School of Pharmaceutical Education and Research, Jamia Hamdard. He will be deliberating on estimation of anti-cancer and antioxidant effect of Unani medicine against liver cancer, a preclinical study. So,
Thank you, ma'am. Very good afternoon to all. And thanks to CCRM for inviting me, for giving a chance to present the project which they have assigned to me under the collaborative scheme. Here I am presenting the part of the project which we have carried out up till now. Approximately 1.5 years we have completed. Two papers are under communication, so all the data will not be disclosed because it is under communication, and the one is under revision. And as soon as the other things will be, the result is declared, we will definitely disclose all the parts. However, now the topic of my project is a little bit different, but here we have modified. Exactly, we are not presenting. I'm not presenting whatever the topic we have submitted to CCRU, and that has been sanctioned. The presentation is basically related to that. That is the estimation of the anti-cancer and antioxidant effect of the Unani medicines against liver cancer. It is a preclinical study. That means it has only been carried out onto the cell lines as well as on the Vista rat model. No human is involved. And in future also, we are not going to have, although when the formulation is ready, the CCRU may utilize this preparation for the further utilization, because we have not used any formulation from the CCRU. Rather, we have chosen different plant. Their aqueous extract was used. There were 18 plants we have chosen, out of which I am presenting only 5 compounds which have shown us the potent antioxidant and hepatoprotective activity. So rest data will not be presented here because they have shown optimum activity but not up to the mark. So that's why that has not been presented here. So here I go. First of all, we have to take up the introduction of the study, and the plant which we have got the potential action related to the antioxidant as well as the HCC, hepatocellular carcinoma activity, inhibitory activity that we have chosen here. So the plant are amla, kasni, chirchita, aftimone. These are only selective. That means the only 4 compounds which plants we are mentioning here. Otherwise, we have carried out work onto the 18 plants. We have carried out the extraction. Here we are explaining only the aqueous extraction method. However, simultaneously we are carrying out dichloromethane extraction as well as methanolic extract also for the comparative study, which have not been incorporated here. And in fact, in our project, we have been asked to use only the aqueous extract. That's why we are restricting ourselves here for the aqueous extract of the plant. Antioxidant activity has been carried out, followed by the hepatocellular carcinoma inhibitory activity was carried out onto the mice. HipG2 cell line was used initially to find out the optimum activity, and where we have found the optimum activity, those compounds were further tested onto the direct onto the Vista rat. Results and discussion, conclusion and some reference. These are the parts. So hepatocellular carcinoma, which is also called as malignant hepatoma, is an advanced form of the liver cancer, which is denoted by the various symptoms, including the skin decoloration, fluid accumulation in the abdomen, blood clotting irregularities, severe abdominal pain, vomiting, nausea, and the other symptoms are also can be seen. Since the Unani system of medicine is being practiced in India for the centuries, and the simple medicament, by using the simple medicaments as well as the murakkab, that is called as polymopharmaceutical preparations, have great significance in the treatment of the various disease, including hepatocellular carcinoma. There are many pharmacopoeial and non-pharmacopoeial preparations which produce significant anti-inflammatory, antioxidant, and anti-cancer activity. However, their potential is still being scientifically studied. So that's why the CCRUM and Ayush is giving the project to find out the potential, because as of now they are using by the literature whatever is available, and we have got they have got definitely the good results. Based on that, scientifically we are trying to justify that the results whatever they are getting is relatively good enough to justify the things. So based on that, the work is in the continuation of the same. To prove the effects of the existing formulation, there is a need to standardize physiochemical and pharmacological the existing formulation which have effects on the HCC. Thus, keeping this view in mind, the present study was carried out to fix the quality control standards of the herbs being used as Unani medicine for the treatment of as an antioxidant and anti-cancer activity. So we have chosen various, as I told you, 18 plants, out of which the amla, the fruit is generally used, which contains various type of tannins, alkaloids, phenolic compounds. And the description about the treatment of the cancer, ma'am has already well explained. So I will not go in detail of the etiology or pathophysiology, all those things. I will directly come to the point how we had carried out the activity and how we have isolated. So this is the various formulations are available in the various formulations are available in the market related to Unani formulation such as Itrifal Didan, Itrifal Fauladi, Itrifal Kabir, Mulayyan, Itrifal Mundi, and many more. These are the preparations which are already containing amla and which are available in the market in the various activities have been reported for that. But amla, as we know, it has a good antioxidant activity. So we have, unfortunately, we have got the justification when we had carried out the DBP pitch inhibitory activity. Kasni is the second plant which we have chosen, that is containing sesquiterpenes, lactones, lecithin, 8-desoxylecithin, and many more compounds, caffeic acid, as ma'am was telling about, which is also part of the etrifal. So this is also present in the Kasni as such. The preparation which are available in the market related to the Kasni are the Iksir Jigar, Maul Hayat, Majun the Bibul Ward, which are basically used for the painkiller as well as they are also for the treatment of the jaundice as well. Similarly, chirchita, which is very rarely used for the Unani preparations. However, namak chirchita and the rak chirchita is available, which are generally used as mukavvi for the purpose of, but very few preparations are available. So fortunately, we have got good results related to the antioxidant activity of these compounds, which has not been reported so far in any of the Unani formulation. Afti which is very well known, and it is basically a parasite bale, which you can find anywhere, and it is the various preparations are available: etrifal, godadi, etrifal, didan, javarish, various javarish, majuns. These are available in the market and which is being marketed by the various Unani suppliers and the producers, including CCRM is also authenticating those. So the simple method we have chosen, we have selected the crude drug of the plant. We have crushed them by using the grinder by hand as well as the mixer. And after a soaking was carried out in water only for the 12 hours, then it was refluxed. And the refluxing was done only at 100 degrees Celsius because the water was used. And wherever the other solvent were chosen, accordingly, their boiling point was used as a extracting solvent. In this case, the water was a solvent, so 100 degrees Celsius was required for that only. And then we had identified various component present. We had tallied it with the available standards. So we found that reported compounds are already present into it because the n number of products was there. HPLC studies was also carried out just to confirm our TEF chromatography procedure, which we had carried out into the glass plate only. So we had just reconfirmed it by using the HPLC as well. After the extraction of the extract, we have concentrated the extract by using the rota evaporator, and then we have freeze dried it, and finally the compound has been converted into the powder form by using the lyophilizer. Then after getting the powder, we had carried out the antioxidant activity using the standard protocol that is called, there are several methods available. We have chosen DPPH, that is 1,1-diphenyl 2-picyl hydroxyl method. That is a free radical squenching method. Radical sequencing method was used in this. We had carried out for the 12 compound, out of which 2 compounds found to be very active. One is the amla, that is a Ambelica officinalis, and the second was the chirchita. Was determined in terms of the hydrogen bonding or radical squancing ability using the stable radical DPPH method. The Molinex method was used for this. He has reported in the literature. We had follows that method only procedure. 100 microgram DBPA solution in methanol was prepared, for which 100 microliter was transferred to the 96 well plate, and equal volume of the dried aqueous extract of the different concentration of the above mentioned drug was added in 96. So we had used 5 concentration: 100 microgram, 200, 300, 400, and 500. So I have only representing the 100 microliter, but we have carried out 5 concentration, and every result was carried out in triplicate just to justify, to find out the accuracy in the result. So this I'm mentioning here only 100 microliter, but in the data the 5 concentration have been shown. ये जस्टिस होगा अभी आपने हमारे साथ तो इतना कम टाइम. Anyways, I will. Whereas methanol and DPPA solution was used as a control, and the change in color was observed in terms of the absorbance using as the 517 nanometer. And experiment was conducted in the triplicate for the sequencing activity, and the percentage inhibition was calculated according to the given formula, and the data is given here. As I told you that we had used various concentration, that is 100, 200, 300, 400, 500 microgram per ml. Amla, chirchita, and ascorbic acid was used as a standard. And you can see that the ascorbic acid, the result was very well close to the ascorbic acid, because the ascorbic acid is well known, having the well known antioxidant property. So these 2 compounds, especially amla, having almost equal to the ascorbic acid. So that's why we have chosen these 2 compounds for the preparation of the murakkab in the further studies. So from the above data, it was concluded, I just told you, I will not repeat it the same thing. So because of time constraint, I will go just to the next screening. And that the second screening was carried out for the hepatocellular carcinoma treatment activity, for which initially the hepatocellular carcinoma was induced by using then, that is dimethyl nitrosamine, followed by the thiocitamide, and this took us to 8 weeks to develop the carcinoma. And after that 8 weeks the drugs were administered by the oral route, because that was cannot be given by the IP route. The oral route was chosen, and specified amount, which I will be explaining in the next slide, that was administered to the animals. And based on that, we had carried out the blood ASLT, ALT, bilirubin, all these parameters were tested, along with the hepatocellular hepatoprotective activity was also carried out by taking out the liver out and making a section of that, and that has also been placed here. So here the standard drug was the sorafenib we have chosen, and again the compounds were divided into 6 groups, each group containing 6 animals. The first group was a normal control in which no treatment was given, followed by the toxic control where the den and TA were only given, that is the diethyl nitrosamine and the thiocitamide, which was basically for the induction of the hepatocellular carcinoma. And the group 3 was the only one drug we have chosen for this Kasni. And the group 4 is we had given the Aftimune. And the third one, we had given the combination of the Amla, Chirchita, and Kasni and Aftimune, all 4 together. We had combined together to make a preparation, a murakkab. So initially we had carried out the individual drug, and then we had carried out the murakkab, incorporating those drugs which had shown good potential for the antioxidant property. So that have been mixed together. A murakkab has been prepared by using the equal quantity, that is 12.5 gram of each, and 50 milligram dose was chosen in that case. So this way, this is a procedure which we have carried out, which I have just explained, how we had induced and we had given the drug. So it was total 16 weeks study. And after that, we have got the following results. The bilirubin we have, bilirubin and SGOT or AST and ALT, ALP and total protein were checked by using extracting out the blood. And in this, where we took the normal control. This was the highest one because in which no drug was administered, only the induction of the hepatocellular carcinoma was done, in which we have found 0.36 similarly. But in this case, toxic control, where the only induction was there, in which we have not given any kind of the medicine with the normal, only methanol was given or the water where is required. In this case, we have induced the carcinoma and no other drug was given. As I told you, that group 3 was the Kasni, group 4 was the Aftimune, and the fourth was the combined extract of the Kasni, Aftimune, Chirchita, as well as the amla, which has been given to the group 5. So if you see the data which we have got with the combined extra murakkab, that is giving out at almost equal to the standard drug, or we can say that the normal control, this is almost close to the normal control. So we can say that the complex which we have prepared, the murakkab which we had prepared, in all cases, if you see the data, this is the 397 where I have the extract, combined extract had given 161, whereas the sorafenib has produced ALT and as well as the AST in a very close range. We can find 58, 60, 57, 161. So we can say this murakkab, although Kasni and Aftimune itself are found to be very efficacious, but when they are mixed together with the antioxidant compound, the potency was found to be more than the others. So based on that, we can conclude that the extract which we had combined together had the better potential, and this is the graphical representation of the data which we have shown there. I have shown there. So based on that, you can see that it's almost equal to the standard drug as well as the normal cell which we have obtained, used. So this is the slides, hepatic cell, sorry. So in that case, this is the normal one. The first one is the normal one. Second one is the toxic. The C, it is mentioned here that first and second is the normal and the toxic control, first and second. The third one is the, and fourth one is the C and D show the moderate improvement as compared to the toxic control, which is basically with the drug Amla and, Aftimune and Kasni and Aftimune respectively. E is basically I showed the completely, which is a mixture of 4 drugs, Amla, Chirchita, Aftimune, and Kasni. That is the E, which has shown, if you see here, you will find the similarity with this, almost the similar kind of the liver we have got. So that means it proves that the activity in the murakkab is found to be equal to the normal one, as well as the standard drug which we have used, that was sorafenib, that is also showing the similar kind of activity. So based on that, we can propose as this could be used, this combination 12.5 gram each can be used for the treatment of the human hepatocellular carcinoma, as well as it can be used for the protection as a liver protective as well. So in the present study, we had used 18 Unani herbs used for the treatment of the various disease. However, the data of only potent herbs is presented here. Among 18 Unani herbs, the aqueous extract of Amla, Chirchita, Kasni, Aftimune exhibited moderate to excellent antioxidant and HCC preventive properties. Hepatocellular carcinoma was induced in Vista rat by the DNTA, as I mentioned earlier. And HCC was also characterized by the loss on the body weight and relative liver weight increase in the relative liver weight. Free radical squelching activity of the selected Unani drugs exhibited that the Amla and Chirchita have good to excellent antioxidant activity when compared with the standard ascorbic acid at a concentration of 100 to 500 milligram per liter. The experimental data of SSC preventive property of Unani have related that Kasni, Aftimune have potential SSC preventive curing property, whereas the mixture of Amla, Chirchita, a combination of the Kasni and Aftimune, excellent SSC, where compared with the standard sorafenib. These are the various references, and the paper has already been communicated, and definitely it will be published in. And the one of the paper is having the impact factor 4.5, and hopefully it will be accepted because it has entered the correction revision. So this is the, I summarize it very faster because ma'am has done injustice because he had provided the sheet to me to have a very limited time. I understand, but I finished, I suppose, within the stipulated time of 20 minutes, I believe. So any question, you are welcome, please.
Ma'am, sir.
Ji.
Sir, I want to know how you confirm. Yeah, one question only. How you confirm this here the animals have undergone this carcinoma? What was your confirmatory test?
Confirmatory test, as I told you, that the increase in the all these things, as well as section cutting, yeah, you have shown a toxic control where the carcinoma has been developed. The second slide, B.
Sir, what was the test?
There were the various parameter we had tested: AST,
So,
ALT,
parameter,
bilirubin,
you mean the enzymes?
enzymes.
I don't.
This is not the second thing is the tumor has been grown onto that.
So, yes,
We
sir.
took out.
Yes, sir.
We took the section cutting of the liver.
Sir, have you checked in the histopathology of these?
Yes, of course.
Sir, before treatment, I am saying.
Yes, before treatment we had carried. That's why the control was kept. In the control, it was not been developed. That was the clean. Whereas after induction, one group was a toxic, in which we did not give any kind of treatment, and the other groups in which the after development we had given the. Yes, please.
Sir, I want to know when you induce the hepatocellular carcinoma to the animals.
Yes.
How you confirm that they have undergone the carcinoma?
Carcinoma, because the tumor was very much evident, and all the related tests were carried out, which confirms that the tumor has been developed. Mere seeing by the taking out, when we took out the liver, it was very much evident in the liver that the glands were developed there. So that is one of the symptoms that in the normal cell this was not developed, but that was very much evident that the tumor has been developed. We have the separate images of those animals as well as the liver also, which has not been shown here. What could be the other things? You just tell me that I will explain exactly what you exactly want to ask. But biopsy was done. Every data is here. That's why I'm saying this is not the everything I'm presenting, because the part of that is already under publication. If it would have been published, I would have presented here. Yes, biopsy, definitely. No, I told at the beginning only, because each and every parameter cannot be shown because the paper is under review. So once it has been published, then the data, ma'am has already published the data. So that's why she is able to, because whatever we are presenting, we cannot publish it. So that's why only those part can be presented here, which has not been published yet.
And sir, one more thing, the bilirubin I think was in the normal reference range in all the cases. Although it was a significant, but it was a normal in all the cases in your control.
In the toxic control, I believe you have not seen probably.
It is in a normal reference range.
In a normal, and the
0.94,
see
0.6.
the second one, that is a toxic control. Toxic control, it was high. It was high. The second one, it was high, quite high. Yes. 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 Definitely, in that case, we could not procure a nude mice and other thing we could not procure. So whatever is available, and that was basically the approved for that is approved onto the Vistar rat. So that's why we had carried on to that only. Definitely, but in that case, we had carried out, we are carrying out, and we have found several research articles published based on that has been chosen, because we have the supportive data which has already been published in the PubMed and the Science Direct and the Standard Journal. So based on that, we have chosen the Vistar right also. Thank you. Thank you very much, and thank you very much. Sorry for this.
Sir, your phone.
Yeah, please. And pen also.
Thank you, sir. Thank you for your patronage. And I'm sorry for rushing you, sir, but our next speaker, Professor Dr. Kumud Bala, ma'am, has to go for the other session as well. So we had to rush through. She's from the Center for Medical Biotechnology, MIT University, and her topic is anti-cancerous drugs in Unani medicine against cervical carcinoma.
वहीं से कर दो तुम. A very good afternoon to one and all. I'm from Center of Medical Biotechnology, Amity University, and my area of expertise is immunology, to be more precise, cancer immunology. So I'm here to present anti-cancerous drug in Unani system of medicine against cervical carcinoma. When we see about cervical cancer, we know that fourth most commonly diagnosed cancer this is in across the globe, and there are the reports say that yearly there is 6,40,000 new cases and 3,42,000 death in 2020 itself. So we can understand the intensity of this cancer, and approximately it has been observed that 90% of the death is because of ignorance, and it happens in low and middle income countries. Cervical cancer, when we come to India, then we see that an Indian population, Indian women, we can see that this is the second most frequently diagnosed cancer, and it is curable. We all know that, but it has to be detected earlier and it has to be treated effectively. And we also know that what is the causative agent of it? This is HPV. HPV 16 and HPV 18 are the main causative agent of this. And despite several advancement in the screening technique and various types of drug, the relapse of this cancer is quite frequent, and this is the limiting factor for the survival of the patient. So we have been focusing on identification of alternative approaches that could reduce morbidity and mortality in this case, and it can also reduce the cytotoxicity induced by the therapy. Recently, many medicinal plants have been gaining importance due to their anti-inflammatory and anti-cancerous activity. When we think about cancer, there are HPV infection has to be persistent, and then precancerous stage come, and then it develops in full carcinoma. When we see the burden of global burden of cervical cancer, then we see that the Asia is where the highest manifestation is there. When we come to India, in Indian subcontinents, we see that India is the prevalence of cervical cancer is quite high in India, and death has been shown in the color red across the globe, and blue is the new cases which is depicting. So the severity of this cancer we can understand. Now, when we go to the traditional system of medicine, Unani system of medicine is one of the oldest system, a- along with the Ayurveda, homeopathy, and Siddha. So, cervical cancer in Unani system of medicine is being termed as Sartan al Rahim, and it is mentioned in many of the classical Unani texts such as Kamila Sana, Tibe Akbari, Zakhira, Khwarzum Sahi, Al Aksir, Al Hawi, Al Konon, Kitabul Mukhtarat Filteb. And there are various techniques also which has been mentioned in the Unani system of medicine to treat this disease. There is dietotherapy, there is food factors that restrict cervical cancer, and the food items with anti-cancerous effect, along with the pharmacotherapy also, where various decoction, merlham are being prepared. There are bath also, a special type of bath where these herbs, medicinal herbs are taken and decoction of this is made. Beside that, Zimad, Hukna is also a type of therapy in it. And there are many anti-cancerous, precisely anti-cancerous drugs specific for the cervical cancer has been mentioned in these texts also. Now, if we go for the Unani system of medicine to treat cervical cancer, then we have Usule, Ilaj, and Ilaj. We all know that cancer is very difficult to treat, but we can definitely restrict the progression of this cancer, and we can provide relief to certain symptoms also, that is ulceration, pain, and swelling, or the inflammation induced by this in this disease. If we consider the dietotherapy, then we have certain restriction on the food item. So in Unani system of medicine, it has been seen that some of the hot and spicy food items has been restricted. However, some of the foods has been facilitated, and these are basically leafy vegetable and high protein rich diet along with fruits. When we talk about the food factors, basically we talk about the trace elements such as vitamin C, selenium, vitamin E, carotenoids, fatty acid, essential fatty acid to be precise, and folate. And these all have certain things to do, certain things to relieve various kind of inflammation in this disease. When we talk about the food item, then we see that garlic, turmeric, ginger, grapes, beetroot, plum, cabbage, red cabbage, aloe vera juice, saffron, green tea, wheat, rye, and pulses are being mentioned in Unani text for treatment of cervical cancer because they are rich in flavonoids, terpenoids, alkaloids, and various acids which are required for treatment of this disease. Now, when we think about the pharmacotherapy which are mentioned in the Unani text, we have oral, oral churn. You can say that is Cuscuta reflexa is one of them, which is a purgative. And in the Unani system, it has been mentioned that there is a imbalance in the black bile and the yellow bile. So we need to control this black bile and yellow bile to restrict the cancer. So this is basically to treat this Cuscuta reflexa is very effective in reducing the black bile and thus treating the cancer. And there are oral decoction also, such as Ziziphus sativus, Cordia latifolia, Cassia fistula, and Prunus amygdalus. So these are the herbs which are taken, and then decoction of this is made, and this is believed to relieve pain due to cancer. And in the second therapy is humul, where marham is made. So herbal plants are taken, and their powder are mixed with beeswax, raisin, and olive oil to make marham, and these are applied externally on the wounds induced by cervical cancer. Then we have abzan, which is decoction. It is a type of bath which is given to the patient to relieve the pain and swelling and ulceration in cervical cancer. And Zimad is another technique which is being used. This is basically an ointment, which is residue left in utensil after boiling water, and then that residue is taken and mixed with the bee wax to prepare this ointment, which is externally applied. And some of the anti-cancerous medicine fruits or the food as medicine, which is mentioned in the Unani text, are Gule Nilofer, Aftimun, Sadabahar, Ruman, Neem, Kisnes, then Kalonji, Amaltas, Amla, Asgan, Gilo, which many of my colleagues has also mentioned by their presentation. Now, some of the anti-cancerous herbs are has been shown over here, which are there in the Unani system of medicine. Now, coming to my research, what I'm doing regarding the anti-cancerous effect, and that to be in case of the cervical cancer. I have used this study has been partially funded by CCRUM, and where we have used seed of Abrus precatorius. These are also known as gunja or rosary bead or chilmati. They are very bright color seeds, and aberrin is the primary metabolite which is present in that, and this make the seed very poisonous. When we go for the secondary metabolite, we have seen that secondary metabolite is very potent antioxidant, and it restricts the proliferation of cancerous cells. So when we have gone for the phytochemical analysis, we have gone for the sequential extraction. However, we have found that ethyl acetate by two method, that is the maceration method and Soxhlet extraction method, that is one is heat induced method. So we have taken both these method. In case of the ethyl acetate, taking as a solvent, and the second is the ethanol we have taken, that is also for the maceration and the Soxhlet extraction method. We have found that ethyl acetate Soxhlet method is full of flavonoids, and in case of the ethanol extract, that is maceration and Soxhlet, both has got phenolic content and they are rich in phenolic content and the tannic acid content. We have gone for these extracts were used for antioxidant activity, so we have gone for the DPPH assay and the FRAP assay, and we have found Abrus picatorius alcoholic extract, Soxhlet extract, quite potent as an antioxidant agent. Now, coming to the HPLC analysis, we have taken three standards. So I will be only talking about the extract potency in terms of the rutin, tannic acid, and piperin. Piperin was not observed in that, and rutin and tannic acid amount was shown in the extract of these. Now, depending on these rutin tannic acid, we have selected certain receptors which get upregulated in case of cervical carcinoma. That is estrogen receptor, GCR receptors, HER2 receptors, VEGF receptors, progesterone receptors. We have taken VEGF also because we have gone for the antioxidant. Beside antioxidant, anti-cancerous activity, we have also gone for the anti-angiogenic activity of these extracts. Now, coming to what we have observed, that rutin is quite potent in binding to the estrogen as compared to the doxorubicin. And tannic acid has been found to bind to GCR, HER2, and progesterone very strongly as compared to doxorubicin. And it is a standard drug which is used in cervical carcinoma. And in case of tannic acid, it has been observed that it binds to VEGF receptor strongly as compared to. So, because there is a small chit in my hand, so I will quickly go through the results. We have also checked the anti-proliferative activity in Hep2C cell line, and where we have observed that Abrus picatorius ethyl acetate maceration was found particularly high in restricting the proliferation of these cell lines. It is shown over here, and we have also gone for the HeLa cells, and there we have observed that Abrus picatorius alcoholic extract, that is oxalate extract, has particularly high in anti-proliferation activity. Then we have also gone for the enzymatic and non-enzymatic activity of these extracts. Later, the results are shown over here. And we have also gone for the anti-angiogenic activity, that is on the CAM model. That is where we have checked the neovascularization in the chorioallantoic membrane. And what we have observed, the aqueous extract of Abrus picatorius was quite effective in restricting the vessel development in the CAM model. We have got two publications. One is in the scientific report, and the second one has been published in, I think it is somewhere here, that is the Journal of Microbiology, Biotechnology, and Food Sciences. And one more article is under review in scientific report, and we have filed a patent also. That is a novel composition and preparation method of green biosynthesized pH-based silver nanoconjugate using ethyl acetate seed extract of Abrus picatorius. And currently, I have got a project in collaboration, a collaborative project from CCRUM, where I have been given a formulation called Maju Naja. It has got 9 herbs in it, and these herbs are Poste Halela Kabili, Poste Balela, Amla, Halela Sia, Turbud, Bisfaiz, Aftimoon, and Ustukud. So we are taking this formulation as a whole formulation, and we will go for the sequential extraction depending on the polarity of the solvent, and we will check whether how effective these are in restricting cervical cancer cell lines. This is all. Not least, I would like to thank my lab members and my coordinators for their constant support and cooperation. Thank you all, and I'm open for questions. Thank you.
Thank you, ma'am. Thank you, ma'am. Your studies do help us and encourage us. Now I'd request our co-chairs to kindly felicitate our speakers. I call upon Dr. Nafis sir to kindly felicitate Professor Alpana ma'am. A flower, a token. Now I request Shiri ma'am to kindly felicitate Professor M. Shahriyar sir. Nafisa Dupla. Thank you, sir. Now I request Nafisa to kindly felicitate Dr. Professor Kumud Malaman. Kumud Balam. Thank you. Now I call upon our dear and our veteran Professor Dr. Shagufta Parveen ma'am to kindly facilitate our chair. Dr. Shagufta ma'am was the Deputy Director of Regional Research Institute of Unani Medicine, New Delhi. She has served us and is now enjoying her retired life. I request her to kindly facilitate our speakers. Ma'am, Dr. Nafis, sir. Kindly help. A flower. Sir. Now I request Dr. Gupta ma'am to kindly felicitate Shri Afza ma'am as well. Thank you, ma'am. Thank you. With this, we end our session and kindly join us for tea outside. We'll meet after tea for a more invigorating and enriching session. We are already late, so I request you to kindly come fast. यहाँ से निकालो, यहाँ से निकालो, तुम उधर से निकालो, तुम दूसरे निकालो, मैं यहाँ से निकालो। डॉक्टर जुगल किशोर बाहर खड़े हैं, वेट कर रहे हैं। तो आ जाएंगे, उनका प्लीज दे दो। तो जुगल किशोर का जुगल किशोर नाइट स्पीकर हमारी डाइस पे कौन सी बस ये दो लोग हैं ना बेबी कोच है फोर पीपल कहाँ है बाहर से बुला के लाइए उनको तो दे वेंकट मैम वेंकट रामन सर को बाहर से बुला लो जो वेंकट रामन और इधरी साहब को बुला लो निर्मला मैडम सीमा मैम को बुलाओ विल स्टार्ट द सेशन जुगल किशोर सर को बुला लो यास्मीन forget all that call them जुगल किशोर सर वो थोड़े से बाल्ड हैं उनको बुला के लाओ और निर्मला मैडम को बुला के लाओ सीमा मैम को बुला के लाओ जो जल्दी बुला के लाओ अच्छा बुला लो जिसको तुम जानते हो उसको बुलाओ कॉल देम we don't have half the speakers half the chair yes वो चीज इन आसमान चला चाहिए ना इन आसमान चला चाहिए ना जो फैंस मैं वो आई थी कहाँ से कौन ले गया अरे मेरे फोन thank you to CCRUM for giving me this opportunity to present on a very important topic. And I think the very theme of the program, where Unani Health is coming in terms with health, I'm a public health professional. So I think this is a beginning of a new era. This is how we have to deal with it. So, for the last 2 decades or so, we know this, that gradually delivered services which are related to healthcare, they need to have a certain minimum quality and standard, which we can perhaps globally benchmark. They should be equitable and they should be measurable, they should be quantifiable. So, with these intentions, the National Health Mission Implementation Framework, the National Health Policy, and various other programs that have been initiated by the Government of India, these were the guidelines that have been followed by them. And there has been enough evidence epidemiologically that our country has achieved immense improvement with respect to morbidity and mortality indicators, be it pregnancy related conditions, be it childhood illnesses, be it vaccine preventable diseases, HIV, malaria, tuberculosis, to name a few. However, there is always some challenges which are posed to the country, especially as large as ours, where there is variability, there is appropriateness of the care that is given according to the clinical condition. All these are posing a challenge, and COVID has just done the best where it comes to posing a challenge to our healthcare facility. So it becomes a very daunting task that the quality management of public health programs has to be in order. So let's define what quality is. It is a measurement of excellence or a state of being free from defects, deficiencies, and significant variations. Quality is the totality of features, characteristics of a product or a service that bears its stability to satisfy those who need it. So, quality management, if you want to define what quality management is, it is basically a management function which maintains various functions, but the four main components are quality planning, quality assurance, quality control, quality improvement. And all of these together, it could be on a product, it could be on a service quality, but the eventual task is to achieve all of these. And it's not a very generic word like quality, but it's all four of these tasks or components which are important aspects of it. So, just to quickly define these, planning is basically all the activities which you plan ahead, which are required so that you can reach the customer's expectation. Quality assurance, very important, is basically means of providing enough confidence to the goals that have been outlined, and so that they can be fulfilled by the customer. Quality control, this is a system of maintaining basic standards that are used for various services. And quality improvement is the combined and unceasing effort of everyone who is a part of the team or who's a stakeholder to lead a better patient outcome with respect to health and learning, so that there are significant changes and incrementally there is improvement from the previous. So, quality assurance, like we said, is essentially quality control plus good manufacturing practices. These are practices to conform to the guidelines which are recommended by agencies that control the authorization and the licensing of the product and the delivery of the goods and the various services. So, to healthcare, it would apply to various applications, to equipment, services, etc. And why is quality assurance important? Basically, there are certain benchmark points to that to meet the rising expectation of the consumers with respect to the quality services which are given, to help the patients to improve the quality, to bring to notice the hospital administration about what are the deficiencies, etc., to help exercise the regulatory functions of the healthcare system or the public health programs, and to eliminate medical errors, adverse drug events, etc. So there are various principles that need to be followed, but due to time constraints, I'm just going to just skip these slides actually. I've been given 5 minutes to conclude. And so let's go on to what the Ministry of Health and Family Welfare, the Government of India, mandates, that to achieve patient-centric quality system, There is a certain framework that we need to follow, like instituting organizational framework for quality, defining standards for service delivery and patient care, continuous assessment of delivery against set standards, improving quality through closing gaps and implementing opportunities for improvement. And there are various frameworks which you can go into the details of it. Like there has to be a holistic approach to the entire program that is being implemented. It should be very clientele focused. It should be focused on the clientele. Recognizing who are the champions. So we need to learn from our success stories. There is a big gap in India that we see over there. There are lots of success stories from various parts, from different states of India to implement into ours, and a teamwork that you have trained personnel who are responsible for certain instructions or certain jobs, and there is a teamwork that is required in order to gain or to achieve quality when it comes to public health programs. And so there is this always a tipping of the balance when it comes to quality in healthcare, because there is technical quality and then there is service quality. So, when you go to a tertiary care hospital, you talk about the technical quality. What was the infrastructure? What was the building? What was the cleanliness, etc.? And then there is service quality as to how well the doctors were trained. So, this tipping of the balance, or to maintain this balance, is kind of difficult in a large population like India. I'll skip these slides which are related to quality of care and the national health policy. I'm sure most of you are aware of what it is. And integration of quality approaches when it comes to planning, assurance, improvement, assessment, and implementation. So we cannot work on one and then move on to the next. We need to work simultaneously in silos with all of these aspects of quality assurance or maintaining the quality of healthcare delivery systems, and set benchmarks which are on global guidelines. And in conclusion, I would say that quality assessment is a very cyclical process. It is a continuous process that has to go on. And for a large country like India, public health, preventive health is the only way forward. So, the Ministry of Ayush is doing great. The Unani medicine is doing great in that aspect, that we are focusing more on preventive health and public health, and that is the only way forward. Thank you. And I'll be happy to take any questions. Thank you, ma'am. Now I call upon Professor Jugal Kishore, sir, Director, Professor, and Head VMMCs and Safdarjung Hospital. He will be deliberating on monitoring and evaluation of public health program. Professor Jugal Kishore, sir.
Respected chairs, Mohammad Idris, who is known to me for longer period now. Other chairs, I don't know much, but anyway, it's nice time that we have come across. And many of you might be knowing me. It's a very difficult topic. I don't know how many of you have done it, monitoring and evaluation. But this is a part of management. And if you have not done it, then the management is not, cannot be. As you have learned about the quality will not come if you don't have the good, process of monitoring and evaluation. Actually, in evaluation, the quality is one of that. Without that process, you cannot assess the quality. That is why this is very crucial. But anyway, you require a lot of time to understand how you'll do the uh, monitoring and evaluation. But we just have the, just orientation. That's enough. Uh, Actually, when we say about a program, public health program, then program evaluation and monitoring does not mean that national program. It can be applied to a smaller one, can be just a research initiative, surveillance system,
policy development activity or outbreak investigation. So there are many public health activities, and all of the activities can be evaluated and monitored. So it is applied on various part of it. Monitoring is a continuous process, and it has to be like collecting data management and seeing that where the deviation has occurred, whatever the course has been defined. So you just see that whether you are following that course or not, that process is going on well or not. So that is what monitoring is, and in that also we require a lot of indicators and parameters. So in monitoring, we need a set of indicators and timeline that it should be achieved by this time, whether it is going on or not. Every day we have to do the vaccination. Then how many vaccination and they are doing it or not. That's what person has to go and observe it. Uh, if you look at it, then it is start with the data. So are we understanding what is data condensed into the indicators? Indicators made the information, and the information lead to knowledge and then action. So that is what indicators are. They are to be developed in a manner which can be measured, which can be assessed properly, which can be observed. Indicator which cannot be like measure, I think there's no point having the indicators. So monitoring answer what, where, when, and how much and how many. These questions has been answered by the monitoring. But when we talk about evaluation, it is how effective whole process is, the effective the program is, the activity is. That's the evaluation. So there is a difference in two. I think some of you might appreciate this, but a lot of difference is there when we say, but they are uh, actually working hand in hand. With monitoring, we can do evaluation better. Without monitoring, the evaluation is not possible. But if you don't have a good evaluation, then there is no point of monitoring, because ultimately purpose of all program is to see that you have achieved whatever is objective you have set for the program, and then seeing that you are doing next time in a next cycle in a better way. It should not be repeating the same cycle again, but seeing that your program is improving every time, becoming more efficient, more effective. So evaluation is a process of determining the value of your activity or the amount of the success in achieving the predetermined objective. So objective achievement is very, very crucial in this, that you see that whether it is achieved or not. It is applied on your research project also. It is not that just you have to talk about the public health. But yes, it's action oriented. Therefore, it's a systematic way of learning from experiences and using the lessons. So evaluation process itself can teach a lot of things to us. So everybody should engage into evaluation. You learn a lot of things, that how the program runs, what problem arise, what challenges can be, and how we can solve it. So these are all part of it. So another one is the evaluation for the purpose, like, what is the scope? So it can be critical analysis of different aspect of development and implementation of program. So evaluation is of more of, your lot of thinking and making things much bigger and better, and seeing that how. So goal of evaluation should be seeing that you have to focus on objective and seeing that everything has been achieved in a proper manner. It is not extra wastage, or whether you can decrease in future. So these all part of it. So if you see that, clarify the objective, access the program uh, appropriateness, then advocate for your efforts and solidity of the support for the financial investment, address cost, and making program improvement. So that's what the goals are. So you must have seen this cycle, that is the planning, implementation, and monitoring and evaluation, and that should continue with all type of program. So whenever you're planning any scheme in Ayush or maybe Unani, I think these all things are important. So there are different types of evaluation, and you can choose one of them, or maybe combination of many. It can be related to basic time. So it can be formative, like, you know, time to time you are doing, like at the process going on or the program is going on, you are from the beginning and implementing, then you keep doing it, kind of monitoring, and then at the same time doing the corrective measures. Then it can be summative in the end. You can do it in some formative. You required, professional person and throughout the process, but in summative you require in the end of the program. It can be baseline, it can be midterm, concurrent, midterm or end term or a final. So many names are there. So it depends on when you are going to do it. So it's depend on the time you design the evaluation. Then who is doing it? So it can be internal person or external person. So, or maybe both. So when it is internal, then it can be participatory. You have a different methods. If you really want to make successful, then you can involve the internal person who is not directly linked with. Then I think it's much better, because if you are doing your own evaluation, I think you will never accept the criticism. So external, independent, and a joint. So in government, and also I think in our system, we should have joint one is much better. Or maybe sometime the internal should be continue, and I think external once in a year, or maybe in the end we can have the external evaluation. So it's a uh, then the types are different. Like, you have the technical on basis of the technical or methodological. Could be a real time, like, every time you're seeing things, how things are going on, so you have a better understanding of the whole program. So say nowadays we have the real time, because we have the IT very close, and we understand the IT. We have a meta analysis. Similar to that, we have, multiple evaluatory measures can be done at the same time in a bigger program, which could be a whole country. So meta evaluation is there. We can select only one sector or theme. Thematic evaluation can be done in a bigger program, like in tuberculosis, the big program in which we can have just a private sector involvement. So how much people are involved, private sector is involved, that become a sector or a cluster. You know, like big company or a government, there are every state is running a program, so we can select a sector. And then it could be just impact evaluation, where programs, whether it has made some impact or not. So there are different. I'll show some more which are very interesting one, which is happening in our government setup. One is the whitewash evaluation, and another one is the eyewash evaluation. They are very, very common. Even sometime our government is also doing it. You have to show that yes, we are evaluating. We are very concerned, but actually it is just a whitewash evaluation. This is another one. Another method of evaluation is a SWOT analysis. You just see the program in terms of the strength, opportunity, weakness, and strength. I think become very easy for you to understand. Then CDC framework for the program evaluation is also there, where you define the standard, and out of that standard, you engage the stakeholders, not only just one. All the stakeholder of the program should be part of it, and you engage them. Then describe the whole program. Then focus on evaluation design. So evaluation planning is done in a proper manner, and involve everybody, and then you can make it. I think this is a rigorous steps. So you do all kind of steps. So I'll just will not discuss about all this, because another method of evaluation is, you know just we have different terms, and you just focus on individual terms, like the goal. So focus on whether the goal is defined properly, whether we have achieved or not. Objective are defined properly, they are achieved or not. Then we have the targets, input, output. We have the impact, effectiveness. So these things you just see one by one, that whether in program these are achieved or not, or they are done in a proper manner. We can do the effectiveness or efficiency and resource type of resource assessment, and seeing things through that. You Look, like any industry, we have the programs in which the program will start with the input. Then there is a process going on. You implement it and seeing that you have achieved something. So we have input, process, and output. Okay, and this output is going to have the outcome or maybe impact of any program. So you always see that whether input is properly, whatever is designed is done or not. So input evaluation can be done, the process evaluation, the output, outcome, and whether the benefit is there. All level you can have the evaluation, and you can then compare with the input versus output. It can be efficiency. It is known as a cost efficiency or efficiency evaluation. When you compare the input with the outcome, it can be effectiveness evaluation. When you have the input versus benefit, it can become the cost benefit analysis, or cost effectiveness, or cost efficiency. These are thoda sa ye. Just finishing. So another one, just touching about evaluation, like the purpose, relevance, adequacy, and progress. So you just observe the whole program and segregate a whole program in a manner. You just focus on the purpose. Like uh, this is exactly defining the objective, whether they are giving some kind of purpose. Is it relevant? Some programs are made in a very haphazard manner and maybe I think may not be useful. So whether that program is made in a manner which is adequate and going to have a very good progress. So you just observe that program in that manner, just seeing the efficiency of it and effectiveness, impact, and sustainability. Any program, if does not have sustainability, obviously it has no meaning, because one has to see that you have run some scheme and it is going to end in after 1 year, and after that there is no sustainability. There is actually the whole exercise is useless. So one has to see these all things in terms of those all things. So steps are there, which I'll not, but the how you will do the evaluation. So evaluation is they specify the subject, purpose, the plan, then a plan for human resource capacity. It is not just one person can do. You just go and observe some program. So one person can do. It's not like that. One has to see that how many people are required, because it need expert in different area. Like the suppose you want to see the budget, whether the budget is made properly and whether it has been utilized properly. So you require some finance person who can understand the intricacy of the finance. Then collecting the data, then you collate and analyze the whole data, then you make the some analysis and making the report. And in the report also you can present in a manner which can give some recommendation for the future of that project and program. So method of data collection, then you can have different kind of data collection. It can be qualitative in nature and a quantitative in nature. Okay, all of you must be knowing what is. I think she's going to talk about the data, but focus group discussion, case studies, in-depth interviews, they are the qualitative nature. And then taking the survey and collecting the data in a bigger sample, like the sample survey, they are all uh, collecting the quantitative data. Then sometime you do the experiments. You can compare that we have applied this scheme in this one district and comparing with the other district where the scheme is not there, and then comparing the outcome and seeing whether this is working or not. So that become a kind of control experiment, where in one experiment is done or maybe some kind of intervention is done, other it is not done. And then sometime you have to see the time, cost involved, and ethical consideration. They are all there, because if it is very good, you cannot do in one district and showing that we have done, because ethical approval is required to do any kind of intervention in any community. Then data analysis, I think she's going to present, then report writing, in which you have to have everything like what was the objective of the evaluation, then approach, what kind of approach you have made, and uh, collecting data, result making, and conclusion, recommendation, and executive summary. Constraints are always there. I think it's always good to tell you could have done in much better, you know, if resources are there, or some expertise are there, or where you have defaulted. So these all things should be written, because this whole exercise of evaluation is making you more wise, making you more better management, better manager, and you can run the program in much better way. So therefore the evaluation should be in a transparent manner, should be producing the report in a manner. It should not be whitewash or a eyewash, something like that. It should be properly done and presented, and seeing that whether the change has occurred, and if it is not occurred, what is the problem. So thank you very much. If you have any question, I am ready to answer.
We will take the answer
Later on.
during the discussion. Put it in the specific slots.
Thank you, sir. Professor Jugal Kishore has always been a patron and has always been with us. Thank you, sir. Now I call upon Dr. Tanika Lingdo, ma'am. She is Scientist E, Epidemiology and Communicable Diseases Division, ICMR, New Delhi. She'll be deliberating on data management in public health research. Ma'am.
So, a very good afternoon to all of you. I would start with first thanking the organizers for inviting me here to give this talk on data management in public health. And so, without wasting time, I'm just going to go to the session. So, we've heard a lot about evidence-based public health practice, evidence-based medicine. So, we know that now most of the decisions that are being taken are always needs to be supported by good quality data. So, this is the whole reason why we are, whenever there is a research in hand, we're trying to focus on the data management aspects of it. So, again, this is generally just to sort of emphasize that when we think of a research question and when we want to develop a proposal to implement that research question, very early on in the process, we need to understand what are we actually wanting to measure. When I say what are we wanting to measure, what is our exposure variable, what is our outcome variable, and of course, we know that it's not only the exposure and the outcome variable that plays a role, but also, the noise, the nuisance factor, that is the covariates. So you need to think through this even at the time of developing your protocols and proposals. So this is just a diagram to show you the cycle of data management. It starts with your research question, and then once you have your research question, which is clear to you, the next thing is what data do I want to collect? Not only what, but we need to also consider whom, where, and how do we collect that. And of course, following all of this, once we know and finalize on the type of data we want to collect, then we think about the tools. Tools in this case are how do we measure these, right? So I'm going to start with how. So we all are aware that there are different types of data collection tools. What do we need to use depends on what is the research question in hand, what are our objectives, and what exactly do we want to measure. So these are just some examples of the data collection tools that are very commonly used. Questionnaires, I think we all know about them. Case report forms or CRFs, and of course, participant diaries. So I'm sure we all are aware of this. Besides this, there are also other data collection tools, but I'm just going to cover these. So what we need to know is what exactly is the difference of each of these. And also, we know that all of these data collection tools, when they are being used, you can either use a paper version of it, or nowadays what we call EDC, which is electronic data capture, is in vogue. So we would go for that. Okay, so when we talk about questionnaires, so this is the tool that we usually develop, and I'm sure all of you have done that at one point in your, research career. So they are usually considered, or when you develop them, you try to have them in non-technical language. And essentially they are useful for capturing maybe some attitude or behavior, experiences, practice, etc. And again, we know that questionnaire can be administered in many forms. So it can be a face-to-face administration, or it can be online administration. It can be self-administered. It can be also a interview-based questionnaire. When do we use what? Depends on, one first thing depends on the type of question. Secondly, on the type of audience or on the type of participants that you are collecting your data from. Then again, most of these questionnaires are questionnaires that are readily available, validated, contextualized. So if you have questionnaires that are validated, then just go ahead and use that. There's no point in reinventing the wheel or developing something from a scratch when it's already there. But of course, at times you may have to develop your own questionnaires because maybe they are not already available. And if you do that, there is an entire process of, again, validating that questionnaire, the tool essentially. So I'm not going to go into that. And this is just to give you an example of some validated questionnaires. And I'm sure all of you all are aware of it, like the WHO quality of life, the Euro quality of life, the GPAC, etc. So these are questionnaires that are already there, available, validated, contextualized. So you can easily use these. You may not be using the entire thing, but you can adapt it to your own situation. Okay. Case report forms, they are usually tools that are used in clinical research. Essentially, when we are talking about, I think Sir talked about controlled trials, your randomized control trials and so on. And in the difference between this and your questionnaires are that here you may use technical terms. They are usually designed to be completed by the researcher, given that we're using technical terms. So, you don't want to give it to the participants because they may not necessarily be aware of the terms that you have used. They collect facts and not opinions or behaviors. And as we all know, when we're talking about CRFs or case report forms in clinical research, you need to collect that data from multiple sources. So you complete your CRFs from multiple sources, maybe through an interview from the participants, or you may want to go back to the medical records or any other logs that is available. Diaries are again oftentimes used when we are doing research, and they're very commonly used. For example, if you are wanting to look at a dietary pattern, or what is the food that you are consuming over a period of time, maybe you might be asked to maintain a diary. Or very commonly they are used not in our country but in Western countries, maybe when you want to document food allergies and things like that. So diaries are again very popular, or often used, frequently used data collection tools. So this needs to be completed by the participants themselves, because they will be keeping it with them and maintaining a log of whatever the information needs to be collected. Can be a record of treatment compliance, side effects, response to treatments, and also sometimes it can be participants' views about treatment. So that was the how. That is, how do we collect through these different types of tools? Now, I'm going to touch upon the whom and where. So, whom are we going to collect the data from? So, that is the target population. So, depending on what are the inclusion criteria. So, every time you have a research question, you want to conduct a research, you need to have a target audience in terms of participants. Who are you going to collect your data from? So this can be, depending on the age. If you have a age criteria, which is a part of your inclusion, then you might have to define the age group, the educational level, then again, sensitivity of the information, from whom you are collecting the information, the type of information that you are collecting, any disabilities. So you need to know if you are going to be administering a self-administered question from somebody who has some physical disability, that may not be the correct way of using your tools. Also, local language. So oftentimes you need to be sensitive to the fact that not all of us can read English, right? So we need to translate if required into the local language. So always important when you're developing your tools to think of who will be your target that you want to tap on, and where will the data be collected from. Then what do you want to collect? Again, how do we know what is it that we want to collect? So this leads us back to our research objective, research questions. So it's always important that when you frame your research question, it is simple. There is a lot of clarity in it, so that the moment you look at your research question, you know what your exposure is. I mean, what your exposure variable is, what your outcome variable is. And then, of course, there are confounders that you need to take care of. So you need to start thinking of it at this point in time when you're preparing your, proposal and writing on the data management part of it. So a good way to start is to develop a data collection matrix and dummy tables. It's always a good practice. The moment you have your research question, you finalize on that, you should try and think of what could be my results like. What do I want to present? What do I want to show at the end of this? So that's when you start thinking of your dummy table. So they're just your tables with you, which you will be eventually filling in with your data, the skeleton of that essentially. So this is a statistical way of visualizing your data. So this is just a data collection matrix. I think we always have this develop when we are, trying to sort of manage the different activities under the research that you plan to conduct. So this is what we call a dummy table, depending on what your research question is. If it is a question where you're only interested in looking at the distribution of a disease, any disease condition risk factors, then you will have descriptive tables like this. But if you want to go ahead and look at, associations, effects, look at the effectiveness of efficacy of intervention, then you will have to talk about tables which are analytical, because the analysis will be based on some analytical statistics. So your table should also accordingly be prepared in that manner. So this is just a descriptive table, that is distribution of your population, for example, in terms of certain important socio-demographic characteristics. Okay, so this is just an example of a question where you have the information on the socio-demographic variables. So you can see this has been developed in a very systematic manner. If you have good questionnaires developed, you will collect your method in a very easy format for you to then translate it or transfer it into your databases, because you know that the moment you've collected data, all of this will go to a back-end database from where you can extract the data for the analysis eventually. So again, so this is the questionnaire, but eventually, this translates into a data sheet, like maybe an Excel spreadsheet for some of us, or even a data access or any other software that I use for, for 4 minutes. Okay, I'll finish in 5 minutes. So yeah, so this is so when you're collecting data, you should be mindful of the fact that you collect it in a way that it is easy for you to enter and visualize it in a data sheet like this, so that you can collect and analyze your data. So a completed table would look something like this, and these numbers are coming from this sort of a table. Yeah. So your data on this is from the data sheet that I have presented. But to get something like this in an easy manner, you need to understand what exactly you're collecting, and then also start thinking of how you're going to develop and present your database. This is a dummy table for an analytical question. That is where you're looking at effects. So then you start thinking, how will my dummy table look like? The moment you know what you want to exactly measure or collect the data that you want to collect, you know your dummy tables, you can then prepare your questionnaires, the date, what exactly information you would want to know. Okay. So it's not only the content of your questionnaire, but it is also important for you to focus on the design aspects. So this is again for ease of looking at it, ease of filling up the questionnaires or the tools. For example, you need to pay attention to your font size, digit, date formats, and coding, question numbering, and all that, so that it becomes easier when you are translating it into your data sheets. And of course, coding of responses is very important, because when you're entering your data, you are not going to be typing out the whole, usually you don't want to enter data in a text or string format. You would prefer to use a numeric format, because that is the form of data that can be analyzable. So that's where coding becomes very important. So these are just examples of types of fields, responses when you are, preparing, developing a questionnaire and planning to collect data. So it can be numerical, that is integers or decimals, or it can just be a binary response, yes, no. Sometimes you might have an open-ended where you want somebody to give their opinion, views, and multiple choice questions, or multiple choice from where you can pick just one, or multiple choice with more than one responses. This is just an example. I'm just going to go through. So just to summarize, when you are planning on developing a tool, so there are certain steps. So you need to list the items you need to collect. Then again, you think of the when, how, whom to collect from, the design aspects of your questionnaire, and of course, once you're done with the first version of it, always remember to pilot test the form on a similar population on whom you're going to be conducting your study. So key issues while designing tools: use dummy tables, data collection matrix to be the basis for understanding what information you want in your tool. Then think of the variables that you're going to be collecting, whether they are, they are variables that are quantitative, qualitative, again, units and the choice of, decimal places, and so on, and avoid duplicate questions. Okay, so I think this is just the same thing, right? Thank you. So this is what you will end up with if you do not manage your data properly. Thank you.
Thank you, ma'am. Thank you for that educational deliberation. I now call upon Professor Mohammed Akram, sir. He is Professor and HOD of the Hafizio Samaji Tib School of Unani Medical Education and Research, Jamia Hamdard. He will be deliberating on evidence-based health promotion. Sir.
Thank you very much, Shaista. Respected Idris Saab, Jugal Kishore Saab, and other dignitaries on the dais, and of course, off the dais. I'll be talking about evidence-based health promotion and Unani medicine. Next, please. Can I have this? Okay, yes. Yes. So during the last decade, concept of evidence-based medicine caused great interest among the health professionals. According to the definition, evidence-based medical medicine represents integration of clinical experience, patients' values, and best available evidence in process of decision making related to the patient healthcare. Here I want to draw your attention that if we say that evidence based, then we only recognize the scientific evidence or clinical research evidence. But in Unani medicine, there are evidences of their practices. For centuries they are using some medication for the betterment of health. So, and these are compiled in the literature. As a classical Unani literature, we find many evidences of their clinical experiences. So that is equally important evidence for having idea from that. so that we can go forward for betterment of health. So, evidence-based medicine application means relating individuals' clinical science, individual clinical experience with the best scientific evidences obtained by the clinical research. The revised and the improved definition of evidence-based medicine is a systematic approach to clinical problem solving which allows the integration of the best available research evidence with clinical experience and patient values. So, clinical experience in one hand and some scientific evidence on the other hand. Evidence-based medicine is the conceptual approach of the physician in making decision related to the individual patient. Unlike this, evidence-based healthcare is somewhat broader concept that includes evidence advanced approaches to understanding the patient's families and doctor beliefs, values, and attitudes. Evidence-based healthcare also relies on the evidence, put primarily those on population level. As we have seen in last 2 years in COVID-19 pandemic, that we were having evidences of efficacy of many Unani formulations having the potential of boosting the immunity. So from that evidence, we have tried in community and distributed many Ayush preparations like Ayush Kada or Ayush Joshanda or many single preparations, single drugs like some herbal drugs. So these were proven as from evidence of our literature. We have got the idea that we can use this preparation for boosting the immunity because we were not having any therapeutic treatment for COVID-19. So we tried it and we succeeded. Evidence-based health promotion is the process of developing, implementing, and planning health programs adapted from tested models or interventions to be address health issues in a ecological context. Evidence-based health promotion and disease prevention require incorporating evidences of the effectiveness of the interventions into the policy and practice. This is important that we have the evidence of certain medications used for centuries in Unani medicine. So we have to incorporate in our policies and in our decision making so that these things can be authoritatively used for the community. Health promotion and disease prevention in Unani medicine. In Unani medicine, the medicine is defined by Ibn Sina as the science which states the condition of human body in health or not in health, and human body either healthy or ill in order to preserve good health. This is the basic objective of Ilmitib in Unani medicine, that we have to focus on healthy person so that we can prolong their health, and the treatment part is secondary in that. Knowledge of management of healthy body and methods of preserving health, termed as Hifzan-e-Sehat in Unani medicine or sometimes Hifz-e-Sehat. The preventive healthcare approach of Unani medicine is based on the concept of Asbab-e-Sitta Zaruriya. There are 6 essential prerequisites. By controlling or by managing their equilibrium, we can achieve a good health. Another concept of health promotion and disease prevention in Unani medicine is based on these 4 models. One is Tabiyat, and another is Asbab-e-Sitta Zaruriya. Third one is Ilaj with Tadbir, and fourth one is prophylactic drugs or concept of Muqabbiyat. Tabiyat, we all know that this is the internal healing power of the body. The only healer in the body is the Tabiyat. The physician is to assist that Tabiyat so that it can heal itself. This concept we utilize in COVID-19 cases, that we tried to introduce the boosting the immunity. This is the core concept of Tabiyat. So once the Tabiyat is enhanced, and it can be effectively combat with the disease and or disease causing factors, so the person may be healthy. Second one is Asbab-e-Sitta Zaruriya. It is a very effective model for preventive healthcare in Unani medicine. Similarly, Ilaj bi Tadbir, there are many tadabirs, but mostly the Dalak, Riyazat and Hammam part of this Ilaj bi Tadbir is effective in preventive healthcare. Last one in or fourth one in this series is the prophylactic drugs or concept of Muqabbiyat. There are many things described in our Unani literature that these drugs are
Mukavviya azai raisa. Sometimes maybe cardiotonic drugs are there, sometimes hepatoprotective drugs are there. So this concept can be utilized for betterment also. I will quickly show that where is the evidence in our Unani literature that these four modules are effective in the treatment or for the maintenance of the health. For example, Firdaus al-Hikmat is a very renowned physician, Rabban Tabri. He wrote a comprehensive textbook on Firdaus al-Hikmat. Guidelines are there for various seasons, age group, and different temperaments. Also regarding consumption of food, sleep, and evacuation and waste matter. These are all related to the Asbab Sitta Zaruriya. In Kitab al-Mansuri, chapter 2 is based on the diet and the drugs and their effect on the human body. Chapter 4 on prevention of diseases and chapter 6 on the health of travelers. Because sometimes as we have seen in COVID-19 cases, we stop traveling. So what are the guidelines for travelers, what they should take and what not to take? These are already mentioned in chapter 6 of Kitab al-Mansuri. Kitab al-Murshid is another important book in Unani medicine, which quotes importance of Asbab Sitta Zaruriya. And Al-Qanun fi Tib is the Bible of Unani medicine, where we have a lot of things regarding healthcare. Volume first is based on dynamics of maintaining the health, approaches of prevention according to the state of the human body, and health promotive measures for vulnerable groups who are vulnerable to the disease, so that we can take care of them. Another important book in Unani medicine is Zakhira Khwarizm Shahi by Ismail Jurjani. Volume 3rd is on Hifzan Sihat, various methods of evacuating morbid matter from the body, and also regimens for children and elderly and travelers also. These are described and encompass the whole concept of preventive healthcare. Another book of Unani is Kitabul Kulliyat by Ibn Rushd. Chapter 6 is based on Hifzan Sihat, where consumption of good kind foods, because this is the base of Unani medicine, that we are relying on the four humors like Safra, Soda, Balgam, and Khund. And the concept is these four humors are extracted from the good diet. So that if we can manage the diet, or if we can modify the diet according to the need or according to the temperament of the person, then only we can achieve the extraction of good humors. And if the humors are correct, then the health will be there. Yes. Another book is Kitabul Mukhtarat fi Tib. In this book, volume 1 is based on the comprehensive description of Asbab Sitta Zaruriya and their applied aspect in the maintaining the health, and specifically care of organs has been given in this book. This is the important part of this book, that each and every organ is given there, where we can give the strengthening things like Mukaviyat concept of the Unani medicine. Another important book of Unani medicine is Kitabul Kulliyat, I have already mentioned. So, prophylactic drug is another chapter of this preventive healthcare aspect of Unani medicine. Unani system of medicine recommends a large number of single drugs as well as compound formulation for the people to stay healthy for rest of their lives. The two drugs are illustrated specified by Unani physicians are Chopchini and Ushba. Many other things are there, but these are the two drugs which are advocated by many physicians. Use of Sikanjabin by Ibn Rushd, use of aloe vera or aloe or murmakki and the zafran. In recent past 2 years, we have seen very effective results of zafran in increasing the oxygen level of the person in COVID-19. Similarly, several prophylactic drugs like zanjabil, kafur, honey, clove, mastagi, and halilajat have been advocated by the eminent scholars of Unani system of medicine for preventive purposes. These are some other example of prophylactic drugs. So, as far as the scientific evidences of these modules, like preventive healthcare modules, these are the studies which proven scientifically that these modules are effective in the healthcare system or for the betterment of health or in case of preventive healthcare. You can see the adjuvant therapy role of Unani medicine, as some earlier scholars were debating the tuberculosis. Because in tuberculosis we have to have certain antibiotics like rifampicin and other drugs, and most of these drugs are hepatotoxic in nature. So if we can use our liver protective drugs, so that it will be a good result for improving the quality of life of tuberculosis patients. So just to conclude, preventive and promotive approaches mentioned by the Unani scholars are of much relevance in the present health scenario. Different lifestyle schedules, dietary modifications, regimes, and even drugs have been recommended to accomplish the objective of health promotion and disease preservation. Thank you so much.
Thank you, sir. And I request Professor Idris to kindly facilitate speakers.
We have
Yes, sir.
comments.
Yes, sir. Your comments.
If time permits, then
Yes, sir. Please, please.
thank you. My co-chairs, there's two very learned and very senior lady besides me on my left side, Dr. Seema Akbar. Akbar itself shows the greatness of thing. And there is the Madam Devi, Nirmala Devi. So, Madam, thank you for being with us, and distinguished participants or listener. Very dry session of this, I think so, because many uh, listeners were left the auditorium for some good reasons or bad reasons, I don't know. But as far as the presentations are concerned, the four presentations were very informative, well researched. Out of three are basically belong to the methodology, right from the Madam Shazina Saeed's research methodology, in which the quality matters. Quality, everywhere. Quality has become the part of our life. When we go to the shop, even the fruit vendors, and we select the quality fruit or quality vegetables from other vendors. So the quality is become the part of our life. Madam, your presentation was very good, and you have completed in very short period, in abstract in 5 minutes. Really, very nice. You have covered the quality parameters and how to manage it. Though in the morning there is a special session on the standards, in which the whole team of Quality Council of India was there, including the NABH and NABCL. The second, the giant of preventive medicine, not in India but international fame, Professor Jugal Kishore ji. So I'm especially very lucky to have the second presentation, which I've listened or shared earlier on the 10th of this month. There was also a pre-activity of Unani Day. So in this same auditorium, he presented very nice lecture. Today's is very effective. He touched the topic of public health programs and its crux, monitoring and evaluation. That is the audit. We simply think the audit is belongs to our finance, but is a performance audit. Here, I know some very senior person, Dr. Nazir Saab is here. He is heading the Chennai Institute. Madams are heading their own regional institute of Srinagar or Mumbai. So they have challenges. How to evaluate the tasks given by Delhi from headquarters? So I think this type of lecture given to the middle office staff, madam. Just call the doctors. He is always away. Sir, I'm very much uh, grateful to you, sir. Whenever you call, he is always there. So he has become the part of our Unani fraternity. Um, the next was Dr. Tanika Lingdong. Very nice lecture on the data. Nowadays, the data has become the currency. The industrialist has gone back. Tata, Birla, Bata, Tata. We have not. We are only listening the Zuckerberg, Zuckerberg, and now the Hindenburg. Sorry, don't take it otherwise. So the data is everywhere, and the collection method is very ticklish. We don't know when we are taxing, we are sending good messages, or we are thinking our phone is very secure, and nobody is peeping his or her eyes between the 2 and 4 eyes. So there are so many eyes, and this is so open to these can the people we call the hackers. So, madam, when we talk about the data, I always say the data security is also there. Perhaps you know the last month there is big hacking of All India Institute's data. Big story. And the whole institute was clueless, not for 1 day or 2 days, but the whole week. And all things are topsy turvy, and the work was remained in the medieval period and writing all prescription by on paper. The paperless has become the now paper. So that was the data adequacy. We still knows who were the hackers and what was their objectives. 20 to 30 millions data were hook off. So this is very important. Last but not least, my friend, my colleague, Dr. Akram, he has very good and very scientifically proved that evidence based. This phrase is not exclusively modern medicines are used, and that's the benchmark to test any study or anything on that scale. And we are called we means the Unani as the experience based medicine. So he is very beautifully and very uh, evidence based proved in Unani system of medicine we have literary evidence 1000 years back. There's given some template regarding how to maintain health and how we can carry out in our whole life. There are the 6 commandments we call the Swabhisiti Zuri. So and so forth things. So all these 4 lectures were very informative and enlightening, from our team and my own personal behalf. I'm very grateful to all the speakers and the organizers, particularly the Director General. He's very dynamic. Or the quality management is 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 in his at the bottom is in heart, at the core of his heart, because there's an evidence. there are 5 or 6 RRUMs hospitals are accredited by NABH. So this credit goes to none other than the Director General, who is the spirit behind, and even the Ayurveda's, the CCRAS is taking the clue from the CCRUM. So this is very good initiative from Professor Asim Ali Khan and his team. So, sir, thank you very much, and thank you, and bearing my dry words. Thank you.
Thank you, sir. Thank you for beautifully summing up the entire session. At the onset, I would like to apologize with our speakers for rushing them through. We had a very strict time constraint, and that is why we had to rush through. I'm sorry. But now I would request Professor Idris sir to kindly felicitate our first speaker, Dr. Shazina Singh.
नहीं मैं कुछ और नहीं सब लोग थैंक यू मैडम
Thank you so much. Thank you. Thank you. I now request sir to kindly felicitate Professor Jugal Kishore sir.
नहीं मैं सर सॉरी सर मैंने कहा कहीं तीसरी लेडी नाराज ना हो जाए
Now I request sir to kindly felicitate Dr. Tanika Lingam.
आइए डॉक्टर साहब बहुत अच्छा
Now I request sir to felicitate Professor Mohammad Akram sir.
लीजिए सर थैंक यू सो मच रील खत्म हो गई क्या रील का जमाना है अब तो रियलिटी का जमाना है पहले होता जी जी अब खत्म थैंक यू सो मच थैंक यू हाय ग्रुप
A
फोटो
group photo. Can we have all the speakers so we can have a group photograph? Come on. And sir, Jugal sir is here. Acha. Shazina ma'am, she's also gone.
हाँ ऐसा कर देते हैं जी हाँ जी वो अच्छा लगेगा जी जी आप ही आ जाइए
Thank you. Thank you.
Now I thank you, sir. Now I request Dr. Mohammad Minhajuddin sir, he is the Deputy Director of NRI UMSD to Hyderabad, to kindly felicitate Professor Idris sir.
तो डायरेक्टर बोल ही दीजिए इनको सर। डायरेक्टर बोल दीजिए। हमारी कुछ असलियत आपको देखते हैं। थैंक यू। अभी इनकी पीछे हो गई।
Now I request Zahir Ahmed sir, Deputy Director, RRIUM Chennai, to kindly felicitate Seema ma'am. Acha, Nirmala ma'am. Now I request Ishtiyaq sir, Ishtiyaq Alam, Deputy Director, RRIUM Patna, to kindly felicitate Seema ma'am.
Full deck. Full bar.
Thank you, sir.
Ladies and gentlemen, with this, we conclude our session. Thank you for being with us. Thank you so much.
अरे इश्तियाक साहब, थोड़ा टाइम मुझे दीजिए। नहीं तलाश थी कि मुझे तलाश थी वो उसको
ठीक है सर, मैं मेरी कर देता हूँ।
सर,
एक मिनट
मैम सर या
क्या? अच्छा, थैंक यू। प्रॉब्लम आ रही है आपको? कोई प्रॉब्लम नहीं है। जरा बता रही थी कि दोबारा आपको वो कराना पड़ा,
क्या
रीओपन
करना पड़ा?
हाँ,
ये सर
वो कर
सर
रहे
जो
हैं।
लिटिगेशन पूरा चल रहा है चलेगा ना,
किस चीज का?
जमीन का और इंक्रोचमेंट का।
हाँ हाँ
अच्छा चल रहा है आपका अभी?
हाँ हाँ जी। तो
काम थोड़ी ना।
हाँ ये डील हो
हाँ
जाएगा
हाँ,
और
नहीं चाह रहा था।
मस्त
डायरेक्शन
हाँ हाँ
कर दिया।
हाँ हाँ
चक्कर में मतलब जो भी दिक्कत आपको आ रही है, मेरा नंबर लो, आप मेरे को रात में जैसे भी कहेंगे मैं वही मैं उसको करा दूंगा। आपके बाद जितने भी हुए सब आपका नहीं हुआ। आप उस ढंग से आज बताया आपने पहले सर राम हो राम सब जानने वाले हैं हमारे, लेकिन